Good morning. Thank you for joining us here today for our conference on healthcare reform. I'm going to give you some logistics in just a few minutes, but first I'd just like to introduce our new director for the Center Health Policy at the Baker Institute, Dr. Heidi Russell, because she's just joined us a couple weeks ago, and new fresh face, and I'll just leave it to you.
Well, hi, and thank you. I'm so glad to see all of you here today. I am very excited to be part of the Baker Institute and the Center for Health Policy in particular. I've been here about 2 weeks now, well, actually 2 full work weeks, and I have to say that it has been the most amazing experience just in this time, with the exception of the HR orientation day, which was nice but incredibly dull. And so every day that I've been here, I've met new people. We've talked about an amazing array of different policy topics beyond just health policy, which I think is really critical to understanding health policy, is to put it into the context of all other policies and kind of world experiences that are happening. So I really am so glad to see everybody here today, and hope you recognize how important and how rare such a type of event is, and what the Baker Institute is able to provide by hosting such events, because it allows us to address our mission of nonpartisan policy analysis, research, and conversation. And so this is what this kind of event is for. Today's event is particularly important for me, not just because I'm here as part of the Baker Institute, but because this event historically has been important for me. This particular conference, the Health Reform Conference, I've been coming. I haven't made it to every single one, but I've made it to quite a few. And I can remember sitting over where Dr. Singh is sitting, actually, and hearing something that pretty much changed my perspective on health policy and how I understand it. And it's not because I hadn't been in the world of medicine, in the world of public health for a very long time, but because I just hadn't heard it in that particular way from someone with that kind of expertise. So there were 2 concepts, actually, 2 concepts that mattered to me over this amount of time. One was that the international nature of pharmacy. The fact that the industry is an international industry and not a national industry. That changed how I thought about healthcare. And the second that came out of this particular conference was the realization that our concept of a nationalized healthcare system is oversimplified here in the US. And when we study the other countries that have a system like that, we realize that it's much more complicated than the US narrative is leading it to be. So as I started hearing this conversation in this conference, it changed how I thought about healthcare and how I taught healthcare to medical trainees and to policy and public health trainees, and how I've thought about it and wrote about it since then. So this has been important to me in my career, and this should put no pressure on our speakers today. But I want us to just really take it as an opportunity to recognize the value of sharing information in a conference like this, and the value of open-minded listening. Because you might hear something that changes where your perceptions have been, and that is what this discourse is all about. So I hope that everyone gains at least one new insight on the US healthcare policy system today in this conference. And this conference also draws a very unique crowd when it comes to the health policy. So we have physicians, healthcare providers, we have administrators, we have third-party payers, the industry, we have businesses, we have the community at large, all in the same room talking about the same topic. And there is not a lot of spaces where that happens. And so I encourage you to interact with the other people that are here in this conference, interact with the speakers during the breaks, and meet somebody new, get a new perspective on what your previous conceptions about our healthcare system are by those interactions. Again, I thank Dr. Ho for allowing me to speak today, and for being part of my recruiting to the Baker Institute. And learn something. Thank you.
Thanks very much, Dr. Russell. So I'm here to give you sort of more the boring mechanics of how things are going to work today. I've got 4 speakers. The conference is actually being live streamed, and it is being recorded for future use as well. But the advantage of attending in person is that you get to ask questions. So the way this is always structured, I have invited 4 speakers. In general, their expertise is on Medicare, commercial insurance, pharmaceuticals, and aging and dementia. But I've told them they're not going to be talking about the most current thing that you're reading in the paper. So we know, for example, that the government shutdown is about the argument over whether we should extend the subsidies for the Affordable Care Act. I know that's it's an extremely important issue for Texans because potentially if those subsidies aren't extended, approximately 1 million Texans are expected to lose their health insurance coverage. So I said, let's not focus on those issues. I would like you to focus on what you think we should be thinking of and keeping in mind in terms of the long run, because you'll find that there are plenty of things that are going on in spite of sort of the arguments and some of the gridlock going in DC. And so you might hear most of you'll hear these speakers talking about their topics of expertise, but they're also going to be putting in things that will sort of venture off into other different topics. So what I always like to do is I've instructed the speakers, even though there's an hour allotted to each of them, they speak formally for 40 minutes. And then I'm going to be off on the side trying to say, stop. And then you get your 20 minutes, and you can ask them about what they presented, but you should also feel free to ask them whatever is on your mind. And from our conversations, we talked last night, and there are people over there who know more about some of the things going on the inside in DC than I do. So feel free, and if you don't, I'll ask them questions. So logistics, the schedule is online, and you can also, I'm not going to give formal biographies about each of the speakers. You can also look those up online. So during the breaks, there's a ladies' room on this side, men's room on that side, and we'll have a lunch later on. So with that, we're just going to dive right in with the first speaker, which I'm delighted to introduce to you, Dr. Michael Chernew. He is he's the Leonard D. Schaeffer Professor of Healthcare Policy, Department of Healthcare Policy, Harvard Medical School, and he's the Director of Healthcare Markets and Regulation Lab at the Harvard Medical School. He probably doesn't want me to highlight this, but he's just sort of finishing off a term as heading up the Medicare Payment Advisory Commission, which is an incredible amount of important work for the federal government. So we're all, even though you may not realize it, we're all very appreciative of the work that group has done for this country in terms of trying to keep Medicare on track and on budget as best they can within all of the constraints. And just interesting factoid, Mike and I went to graduate school together at Stanford, so we've known each other for, I guess, 35 years or something. But with that, I will hand it over to you.
So, thank you, Vivian. This is my first time at Rice and at the Baker Institute, and I am thrilled to be here. It's amazingly an impressive place. And I couldn't be happier to be invited, and to be here with the other speakers is a great honor. So because I know Vivian's going to tell me to stop any minute, I'm going to jump right in. I'm going to talk about Medicare payment policy, challenges and solutions. We'll see how you feel when I'm done, if there's more challenges or solutions. But as Vivian said, I chair this thing called MedPAC, which is an independent congressional agency. And so what I say now are the opinions of Michael, not the opinions of MedPAC. So just so you know. So here's the key thing. The projections of Medicare spending growth going forward reflect largely assumed increases in volume and utilization. Medicare prices, once you adjust for inflation, are actually declining. If any of you are in the hospital industry or physicians or working for medical groups, I think you understand. We may have a pricing problem in the United States. That's not the Medicare problem. The Medicare problem is not that prices are too high. We have a demographic issue. There's a lot more people aging onto Medicare, but we're not really going to change the demographics. So the real challenge for Medicare's fiscal situation, which I actually think is fundamental for the nation, given the scale of the Medicare program, is actually how we control volume and intensity of services used, which are projected to grow at roughly 3% a year. And what I mean by that is more services, more expensive services, so shifting from an X-ray to an MRI to a PET scan or something like that, shifting from lower cost sites of care, say a physician office, to higher cost sites of care where there's a facility fee. All that stuff is in volume and intensity, and the key fiscal challenge in Medicare going forward is going to be how do we control the assumed growth in volume and intensity. And so that's basically, I'm an economist, by the way, so I'm going to talk about money, not health, but I'm a nice enough guy. I like my wife, my kids. I care about everybody's health. I'm just not going to talk about everybody's health. So I'm going to talk about several different approaches to control volume and intensity, mostly from a financing perspective. The first one I'll call unfettered fee-for-service. Maybe I should have called it minimally fettered fee-for-service. I'm not really sure what fettered is. But in any case, the idea is you pay fee-for-service with very little constraints. People go to the provider they want. They get the services they want within relatively loose limits. There's another way of paying, which is called episode-based payment. So you pay a bundle for, say, a knee surgery or a hip surgery or some other sort of a childbirth, some sort of defined type of service. That's called episode-based payment. BPCI stands for the biggest program bundled payment for care initiative. Then there's something called ACOs. I should ask how many people have heard of ACOs. That stands for there we go, like 5, but I'll go with great. They stand for Accountable Care Organizations. It's basically a population-based payment approach. The way it works is patients are assigned based on their care patterns to a primary care physician. There's typically an organization that employs that primary care physician, so think about a medical group or a healthcare system, and that group is giving a spending target for all the people assigned to them, and at the end of the year, or actually it's a little bit past that, but we'll just go with the end of the year for now, if they spend above the target, in some cases they have to pay money back to the government, and if they spend below the target, they get to share some of the savings. So that's how it works. Essentially, it's a capitation type model, but it's not full capitation. There's some risk sharing on either side. But the key point in the Accountable Care Organization is the organization that employs the primary care doctors of the individual is now accountable for clinical and economic outcomes for those populations of patients. And there's very few other constraints. And then there's a global budget approach, which actually I'm not going to talk about much, but in Maryland, this is actually what happens in a lot of other countries. You give the hospitals a fixed amount of money, a global budget to the hospitals, and then the hospitals have to care for whoever shows up. But Maryland had a system that's sort of like that. And then Medicare Advantage is health plans. So they get a premium. It's a population-based payment, and the plan is responsible for managing all of the care and everything that happens within it. As I go through these, I want to point out an important thing. In this world, waste becomes an asset. So there's a lot of excess utilization in parts of the country. You can decide what's excess or not. That's complicated to define. But the point is, these models assign that waste to an organization. Think about Medicare Advantage to a health plan. If that health plan can reduce the utilization, it keeps the money. So what you want, if you're in an ACO and you're an organization with primary care physicians and you get the spending target, if you reduce the waste, you keep a share of the savings. So what you want is you want to take accountability for a spending target, and if you're good at managing care, you then get to keep the profits if you can do a good job. And so a lot of what's happening here is we're assigning to different groups in the system the amount of waste, and then they get to keep it. So in the episode-based payment model, if you're a knee surgeon, you keep the waste if you can do it more efficiently, some version of that. So the broad approaches, and this is sort of what I would say to do if you were asking me, and I have no power, is you have to fix fee-for-service. I'm going to talk a lot about fee-for-service. You have to support these alternative payment models, ACOs and episode-based payments. So in my opinion, you need a foundational ACO model, and you add episodes when it doesn't cause problems, and I'll talk about that in a little bit. We need to improve the model designs. The way that the system was originally designed, if you're in an ACO, you get a spending target, and if you save money, you share the savings, and you know what they do then? They lower your spending target. And that is a recipe for disaster, because eventually you're not going to be able to save more money. And so I think we need to change the designs. And then I'm a big fan of Medicare Advantage. If any of you follow the health plan world, it's just we have to fix the way it's designed, because right now we're spending a lot on Medicare Advantage. Is that 2 minutes I've been talking? It's a psychological problem. I talk too quickly. Almost always at this stage, if you were able to ask questions now, someone would say, well, what about prevention? And someone's going to say, we have a sick care system, not a health care system. We need to keep people healthy, or some version of that. And we need more primary care. And so as an aside, I'm a fan of prevention. I'm a fan of primary care. It just turns out that those don't save money. And we can talk about why they don't save money, but maybe they could save money. I'm not saying they would never save money, but if you look at all of the efforts in, say, preventive programs or improving primary care, it's very hard for them to save money for a bunch of reasons that can come up. Usually this is when this talk goes south, but you're going to have to wait till the end for you to question that. So I really think the issue is, if you want to save money, you need to design a system where people have incentives to save money, not design a system to bring more people into the healthcare system. Because usually once they get into the healthcare system through prevention programs or primary care programs, you think you're preventing things, but someone finds, oh, there's a little something wrong with you, you have mild chest pain, and you get referred to an ED, they run some diagnostic tests, and before you know it, you're spending a lot more money. So I'm going to start with fee-for-service. First thing I want to point out is, why do we even have a fee-for-service system? So the Medicare statute says that Medicare beneficiaries can get, nothing in the statute will interfere with the practice of medicine, which is broadly interpreted, very loose restrictions on the care you get, very loose restrictions on who treats you. And there's Medicare beneficiaries that want that freedom to go to the doctor and get the care that they want. They don't want the government telling them you can't have an MRI. And that's a reasonable thing to want. It's also important because the fee-for-service system becomes the foundation for a lot of these other things I'm going to talk about. So we need a fee-for-service system. The low-hanging fruit is to fix it. Two quick things. One is, we pay more for the same service based on where you get it, if you get it in a hospital versus you get it in an office. So the idea is you want site-neutral payments so that you're not financially incenting somebody to go to one site or another site. And there's a ton of mispriced codes. We pay in a fee-for-service for all these little things, small, there's like 50 codes for a CAT scan based on the nature of the CAT scan. And a lot of the prices aren't right, and we need to fix them for a whole bunch of ways. One problem is primary care is typically undervalued. A lot of specialty care is typically overvalued. And there's a lot of things you can do and a lot of reasons why you can talk about mispriced codes. MedPAC talks a lot about mispriced codes. But the problem in fee-for-service is the way we've controlled spending in Medicare is just to have fees go down. So in the picture on the on your left, I can always have to, anyway, I might hurt myself. The bottom set of triangles, that's how much physician fees have been rising. The middle line, that's inflation. So the thing to notice, physician fees are rising less than inflation. They've been losing about 1% per year relative to inflation, if you're a physician, for professional services broadly. Spending, by the way, is the top line. It's going up a lot. Why is it going up a lot? Just as a hint, volume and intensity. The problem is the volume of service. So we're spending a lot more, but per service, people are getting paid less relative to inflation. The slide on the right is hospital margins. The top line is, actually the bottom line is average hospital margins for Medicare patients. And in case you can't read the vertical axis, now in 2023, we're at about -12. That's a -12% margin. For hospitals. The top line, that's the MedPAC defines efficient hospitals. We can debate the methodology, but the point is, the efficient hospitals, their margins are -2%. We are not paying, Medicare is not paying hospitals close to what the average cost of care is. It's more than their marginal cost, but that's too econ-y for me to get into, but it's less than their average cost of care. And that's being, the hospitals can survive because it turns out commercial's paying more than this. But at the Medicare level, we're sort of coasting on those higher commercial prices. But the big problem isn't just fixing the prices. I think, and this is sort of key point number one, fee-for-service is inherently ill-suited to deal with the fundamental problem, which is volume and intensity. There's an average marginal cost issue. If you pay the average cost, right, that's going to be above the marginal cost takes the fixed cost out. So if you pay sort of the average cost, taking out, including the fixed cost, that's going to be above the incremental cost. So there's a big incentive to serve more patients, right? If you try and pay the marginal cost, which is closer to what Medicare is doing, then you don't have the same incentive to serve more patients, except no one's paying the fixed cost. The way our system's working now is the commercial payers are paying the fixed cost. But it's hard to get that to work. If you have a big Medicare payer mix, you're often in trouble. And we've done some work, hospitals that have a big Medicare payer mix, they're more likely to close, merge, a bunch of things like that. There's problems getting the prices right because of economies of scale and scope. A big place is running their MRI machines 24/7. They can do it much more cheaply than a rural place that isn't. Getting the price right for the same is hard. It's hard to allocate all the indirect costs. Costs change over time. Cataract surgery is the classic example, which it was expensive and then it's not, but getting the prices to adjust is hard. And even more importantly, if you set the price equal to the cost across the different sites, there becomes a lack of incentive for substitution because you've set the prices so the profits are equal, but you don't want profits to be equal. You want the more efficient service to be more profitable, so people substitute. But fee-for-service tends not to do that. So I actually think these are inherent fee-for-service problems. Which brings me to ACOs and maybe a bit on episodes, but I'm mostly going to do ACOs because I'm probably now at a half an hour. So the evidence is utilization in ACOs, these population-based payment models, go down. Not as much as in Medicare Advantage, but utilization goes down. Quality, I think, is marginally better, maybe not, we could debate it. Medicare spending, even after you share the savings, is marginally lower, and the benefits, cost sharing and stuff is basically the same. The design of these matter. So there's this issue about if you spend more than your target, should you pay back? That's called downside risk. In my opinion, it's not necessary, but if you don't do it, you have to design around it because you can't give money to everybody below and not take money back from everybody above, or else you'll spend more money. There's this issue of regionalization. Do you get paid a target for you or a regional target? The problem with a regional target is it makes all the below regional spending groups want to join, so then you're going to have a problem designing that. And then there's this issue of the ratchet problem, which is if people succeed, you can't take their money away. Who wants to participate in a system like that? This is just a bunch of evidence, but the key point is the second to the top, the second from the bottom line is the study that we actually did, which showed about $25 change net beneficiary per quarter. There's a bunch of other estimates that actually show a lot more savings, but generally speaking, that's the magnitude. You're saving a few percent, and it grows over time, by the way. So I think best case, you're saving 3 to 5% in ACO models net. It's mostly through independent physician groups. That's the graph on the left. Hospital and integrated systems actually don't save a lot of money. And my line about that is if you want to keep people out of the hospital, that's hard if you're a hospital. Anyway, the key point, and I don't know if you can see this or even if you care, the top line is Bruce Springsteen. There's Born to Run and The Ghost of Tom Joad. You probably don't know The Ghost of Tom Joad. That's really actually the point. But the key point is when you're trying to design, that's Terry Bradshaw. I don't know how well that plays in Texas. I'm from Pittsburgh. But in any case, the key thing here, Terry Bradshaw's rookie season stats were atrocious. You have to judge things by their potential. The problem in the ACO debate is people look at things that were poorly designed, say they didn't save all that much, we got to get rid of ACOs and go back to fee-for-service. Imagine if that worked with airplanes. You see those videos of airplanes, they never really take off the ground at the beginning. You got to keep working on these things. I think the concept is right, and I actually think they do save money, just you have to make them better. So a few things on episodes. I'm not going to say a lot. The evidence on them in general is mixed. I think there might be some differences between medical and surgical episodes. Surgical episodes are easier to do because there's a clear trigger. Medical episodes are harder. One of the problems is if everything's in an episode, the episodes overlap. Clinical care is much more complex than an economist would make you think it is. People that have diabetes go into the hospital and you have a sepsis episode, and it's complicated because they overlap. So getting it to work is hard. Assigning the waste to different people is hard. Should it go to the specialist or the primary care doctor or the hospital? The variability of benchmark trends is a real problem, and the key thing is if you give all the low-hanging fruit savings to the specialists, no one wants to be in an ACO because it's much harder to save money. So I think episodes are important, but they have to be designed to be synergistic with a population-based payment model. So the trade-offs is incentives work better if directed to the organizations that control the incentives. Often that's specialists, think skin substitutes. Right? It's hard for primary care doctors to control the use of skin substitutes. But if you assign the waste to a specific specialist, It's going to be problematic. It's going to siphon savings away from the ACOs. People aren't going to want to participate. And so I think the core thing is if you have a big system, you can put them in a population-based payment model. They employ the primary care doctors. They employ the specialists. They can manage and substitute however they want. That works well. But you have to set the system in a way that forces those big systems to save money, because otherwise they're just going to keep operating in a fee-for-service world. It's a design issue, I think, not a conceptual issue. How am I doing? Okay, so we're going to have a lot of time for questions because I don't think I've breathed yet. No, I don't. Okay, I'm going to go super slow. I'll go back and do it again. Is that okay? All right, so Medicare Advantage. Medicare Advantage is the health plan version of this. And so the way Medicare Advantage works is the Medicare Advantage programs in an area are given a benchmark. It's a spending target. They bid against that benchmark. And when they bid, if they bid below the benchmark, which almost all of them do, the gap between the benchmark and the bid can be, a portion of that can be taken and funneled for more benefits for beneficiaries. Lower cost sharing, lower premiums, vision, dental, hearing, worldwide emergency services, chiropractic services, acupuncture, nutrition, transportation, a whole bunch of things. Medicare Advantage has a bunch of tools. They design the networks in ways that ACOs can't. They control the benefits. They control the cost sharing, for example, in ways that ACOs can't. They do prior auth in ways that ACOs don't. And they save money. If I were guessing, we can see what the other speakers think, but I'm going to go, they provide A and B services. I'm going to go 10% for 10% less money, give or take, one way or another. That's going to be my estimate. The quality care is about the same. In some ways, I think it's better, in part because they also lower the drug costs. People get access to more drugs. Drugs turn out to be really important. So they save money. They improve quality that way. There's some concern about some of the networks. So if you need cancer care or other type of really specialized care, it might be that your preferred provider is not in the network, or that you needed some care and they said no in their prior authorization process. So there's some, I think net, it's about the same quality. Later I'll tell you there's a lot of heterogeneity across plans. But here's the key thing. They deliver care more efficiently than ACOs deliver care, but the government spends more. And I'm going to talk about why in a minute. You can debate the number. The MedPAC number is going to be around 20% more. If you told me it was 10 to 15% more, I'd say, sure, that's kind of reasonable. Why are we arguing between 20 and 10? It's going to be basically, it's more. But the key point is they take that extra money and they provide more benefits to people. You get stuff. That money isn't wasted. It's given to beneficiaries because, maybe this is not a secret, the standard Medicare benefit package isn't great. You have a lot of out-of-pocket for co-insurance for Part B. There's no out-of-pocket max. There's deductibles in the hospital system. You have to pay when you go to the hospital. A whole bunch of things like that. And most people that are in the traditional Medicare system, that's fee-for-service and ACOs, they buy a supplemental Medicare insurance policy themselves, which fills in all those gaps, which is why it's aptly named Medigap. Some get it from their employers. The Medicare Advantage plans do that, and they broadly do it for free to beneficiaries. So in that sense, if you're willing to deal with the network restrictions and the utilization management, it's actually a really good deal. Why do we pay them more? We pay them more for a bunch of reasons. Some of them is in the law. So some counties, the benchmarks are set at fee-for-service. They set them at the same rate as you would get in fee-for-service. But in other counties, it's 115% of fee-for-service. So it's not surprising. If you pay 115% of fee-for-service, you're going to pay more than fee-for-service. That's just how 115% works. Right? Some counties are 95%. When you balance it out, they pay more. They're given extra money if they meet some performance targets. Would be great if the performance measures were actually good, but they're not. But they get paid more for quality. But the big thing is what's called coding and selection. And that's what actually the current debate is about. So what coding means is If you're a Medicare Advantage plan, or an ACO, by the way, there's a different system in ACOs, you get paid more if your patients are sicker versus healthier, which makes sense, right? You want to give an organization a higher target if they have someone who's 95 with 7 chronic diseases versus, or I should say my dad is 90, he will get paid, you'd pay him more than you would if someone was, say, 65, and some version of that, and the diseases are adjusted for as well. But the problem is, for the disease measurement, it's not clear what diseases people have. And you know how we figure out what diseases the people have? We ask the plans. And the plans do a better job of documenting the diseases that their members have than would happen in fee-for-service. And that gap, the Medicare Advantage plan's ability to identify people with diabetes, sepsis, congestive heart failure. There's a lot of diseases. I only have 5 fingers. There's more than 5 diseases. But anyway, however many diseases there are, the Medicare Advantage plans document them better, and because everything is based off of fee-for-service, that greater coding means more money flows to the Medicare Advantage plan. So coding is one. The second thing is selection. The way selection works is, so again, my father's 90, he's actually 89, so I hope he's not listening. But in any case, my father's actually very healthy for 89. So within any group of people, there's people that are going to use more care and people that will use less care. The Medicare Advantage plans systematically attract the people within any category that will use less care for a whole bunch of reasons. Maybe because they're relatively healthy given what you observe about them, or maybe because they're like my dad, you just don't like going to doctors, and so you use less care. Whatever the case is, they're paid for sort of the average cost of a person with congestive heart failure, but the people they attract spend less than the average person with congestive heart failure, and that allows the Medicare Advantage plans to get paid more than the people otherwise would have used. So that's why we pay more for Medicare Advantage. If a measure of how much they're getting paid is what's called the rebates. And the way that the rebates work is, I told you, if you bid below the benchmark, a portion of that goes back to beneficiaries in terms of more benefits. That portion is called the rebate. Through 2015-16, the rebates were about $80 per month, $90 per month. Now, the rebates are $211 per month on average. We're basically paying 2.5 times enough so that the benefits are 2.5 times better than they were in 2015. So I can't remember 2015 all that well, but the point is, the world wasn't a disaster then. It's just a much more generous program and a lot of that, I think, is because of changes in coding and selection. What is the benefits going towards? So most of it, the 43% of it, if you look at the column that's under on the far right, is going to reduce cost sharing. So you pay less when you go to the doctor, pay less when you go to the hospital. It just lowers your cost sharing. About 28% is going to non-medical stuff, for at least conventional plans, and some of that's premiums and a bunch of other types of things. So they buy down your Part D premium, they buy down your Part B premium, a bunch of things that are sort of premium oriented, and then the rest goes to other benefits like vision, dental, hearing, and all those other things I mentioned. So you get more stuff because the plans are paid more than they would have in fee-for-service. One of the things that's hard about Medicare Advantage policy is we talk about like it's all the same thing, but there's widespread heterogeneity across Medicare Advantage plans. This is a graph of the coding. On the far right, you see estimates of how well some plans code. I won't mention whatever you think the plan is on the right, but they do a much better job of coding. Other plans, I'm not sure if they still have their management, but anyway, on the left are coding a lot less than average. The same would be true for selection. There's widespread heterogeneity across plans. So the solution to Medicare Advantage cannot be or should not be, let's just cut them all, because some are coding and doing better, and the Medicare Advantage program is predicated through this bidding on competition, and if you lose the competition, then you have a real problem in how it plays out. So what changes should occur, if any? I'm not going to talk about the changes, but what we want, I can if you ask me. We want changes that reduce the returns to risk coding. Actually, they put in place a new model to do that. If you looked at my original graph on rebates, you would see they flattened out. That was after the new risk adjustment system, and I think they'll continue to do that. I think we want to reduce the amount of time and effort that's going to quality documentation, which I think is actually adding very little to actual quality. And so I think the STARS program, which is the quality program in Medicare Advantage, is in need of reform. That's the I'm being live streamed version of that sentence. What do we want? We want more focus on care redesign. We can talk about exactly what that means, but delivering care more efficiently in more effective sites. And we want to improve beneficiary satisfaction. I don't know if any of you are or know anyone in Medicare Advantage, but the choice burden of deciding who's in your network, what's going on, do I get covered for this? Do I not get covered for this? How comes my prior auth working? Who's my actual insurer? Where's my dental coverage coming from? The choice burden of dealing with the plans is increasingly causing Medicare beneficiaries frustration. That's also the live streamed version of that sentence. All of these things, it's on the little floor in my slide, so you can't see it. That's my fault. But technology we can make technology help with all of these things. Technology helps. My personal view is we need to pursue better technology, but we can't use technology as an excuse not to make other reforms, which often you hear people say, yeah, this is all a problem, we're going to solve this with AI. I find the AI debate increasingly frustrating not because I have anything against AI, I'm perfectly fine with AI, but because it's often used to stop people from doing other things that I actually think also need to get done. So some concluding thoughts. Medicare has to slow the growth in volume intensity. Just fiscally, we are not going to have Medicare growing 3% real and solve that with lower prices going forward. We need to find some way to deliver care more efficient. Fundamentally, our problem is how we deliver care. Fee-for-service, in my view, is ill-suited to meet that challenge. That's not to say we can't improve it. We're going to need fee-for-service. We just have to improve it. There's a lot of ways to improve it. We need, for that reason, to build alternative payment models. Those are basically the fetters around unfettered fee-for-service. All the other countries have fetters. They limit the number of doctors. They put global budgets to the hospitals. They control the amount of specialists. They do a whole bunch of things to control the way fee-for-service works. In our version, that's alternative payment models. We need to continue to work on building them. They have a lot of design challenges themselves. I personally think they're more surmountable than the fee-for-service design challenges, and that's worthy of debate. I think Medicare Advantage is a completely reasonable alternative. I'm a supporter of Medicare Advantage. It has an efficient provision of care, but we have to reform it if we want it to lower Medicare spending. If Medicare Advantage is simply a vehicle for financing more benefits for people, that's a policymaker choice, but it's not going to lower spending. And so the key policymaker challenge, which I know is frustrating, is they have to navigate the trade-offs between payment and benefits. And my personal view is we need to pay the plans a little bit less. Benefits will go down a little bit, not as much as the payment cuts, because the plans will adjust in a bunch of ways to absorb some of the reduction in payment. We don't know what the bounds are. I think we need to go slow and move in that direction. The other thing that I don't get says, in you see I just use clip art, like that's my real, just going online, is I don't think we pay enough attention to the sort of the core point that execution matters. So I spend a lot of time giving broad advice about go this way, go that way, do this, do that. The best laid strategy can falter if you execute it badly. And it turns out that mediocre strategies can do well if you execute them well. So don't underestimate the actual doing turns out to be as important as the decision about what to do. And too often we think if we just pick the right direction, it will work, but then we don't execute or implement it well. And so I think it's important for people that are sort of in this sector to understand it, how it works, how well the policymakers understand how the industry is going to react, and how they make it feasible for people to succeed. Some of the things that happen in policy, they want to do X, Y, or Z, and they put in place a bunch of rules that means that the direction was right, but they've designed it in a way that there's just no way a reasonable person is going to succeed in that basic design system. And so the execution of both policy and practice matters. And so I guess this is supposed to be inspirational. We'll see if it is. It's Lily Tomlin, who I don't know if that's who you go to for inspiration, but the line is, the road to success is always under construction. There is not a magic bullet. Well, there's 3 more speakers, so maybe there is, and I don't know. But maybe at the end you'll know. But my general view is we've been at this a long time, and health is really important. I've been talking about money, but the easiest way to save money is just don't give everybody health care, right? We're in this because we want people to get access to health care. You need health care. Health is amongst probably the most important thing for the well-being of folks. Because it is so complicated, we have to continue to work to try and get both the policy right and the delivery right. That's going to require a lot of things. My general view in Medicare is we need to set a system that gives the providers enough flexibility to provide, and the incentives to provide efficient care in a way that as a country we can afford. And how that plays out is hard, so we're going to have to keep going down this road, and I think we're in that path. So now I'm done. How did I do? Did I get to... I'm going to stand over here. I'm tired of doing my thing.
Yeah, so that was terrific. I forgot to explain. So in terms of Q&A, we have microphones that are somewhere, and so you can stay where you are and just raise your hand if you have a question, and the microphone will find your way to you, simply because there are people listening online, so we want them to hear your question as well.
I'll repeat the questions and just shout out. I don't know if the people online...
Do I get,
No, go ahead.
okay. About 2 months ago, I ran across an article that talked about Medicare Advantage.
Yeah.
Okay, and what it talked about was taking some of the procedures that the insurance companies have for rejection,
Yeah.
and doing trials in different states with Medicare,
Yeah.
basic Medicare. And I'd like to know where you think that's going, because we have had friends that have initially signed up for Medicare, eventually felt it was under false pretenses and bailed out. And so we're not real fans of Medicare Advantage.
Yeah. I'm going to stand there to hear the questions and stand here to answer them. It's just a steps thing. So yeah, this is the issue with Medicare Advantage. There's a wide variation across plans, but they have what's called utilization management. So your doctor says you need to have back surgery, and the plan says, no, you don't. And then there's a lot of back and forth, and people are left very frustrated that they don't have back surgery. And your question is, well, we'd like to know if back surgery works. We need better evidence to know whether you should get back surgery, whatever happens to be. And so I think the direct answer to your question is, I believe there will continue to be a lot of work to try and understand what medical services work or don't work. And the key point here is, in what situations? The problem with a lot of these services is that it's not that the service itself are good or bad. It's the specific clinical situation for the specific patient, whether this patient should get, and again, I'll pick back surgery mostly because I can pronounce it, but medicine is complicated. And the one thing that I guess I need to say in response to that, which is important, is from the 70s, the lead person was a guy named Jack Wenberg, who was at Dartmouth, demonstrated dramatic variation across the country in the utilization of care. Medicine is practiced differently in Houston than it's practiced in Boston, than it's practiced in Washington State, than it's practiced in Topeka, or for that matter, Pittsburgh. And it would be nice to think we could do enough studies to know exactly what the right thing to do, and we should do more, and we will, but a lot of it becomes an art. So there's room for pushing back on what is often not care that folks should get. And so the challenge in Medicare Advantage is there is some utilization management. Sometimes they're denying things potentially that they shouldn't deny. On balance, I think they do a pretty good job, but that doesn't mean in any particular case people feel like they wanted to get all the care that they needed. And with the plans have a role, whether you like it or not, which is, you agree to our restrictions, we will give you vision, dental, hearing, lower premiums, lower cost sharing. That's the trade-off. And on balance, the plans will say your care will be as good. In fact, on balance, your care might be a little bit better for some reasons, but there will be situations that you're not going to like and some hassle that you have to do. That is the trade-off for lower premiums, lower cost sharing, vision, dental, hearing, etc. And so the goal, in my personal view, is this quality program should focus on where the plans are really doing bad things, as opposed to what the quality program is focused on now, which is making sure that your diabetes is well managed. And I think we need to reorient the quality programs to make sure that nobody is getting substandard care. But there will be restrictions, and inevitably there will be people, and for that matter physicians, that feel that those restrictions were overly aggressive. Sometimes they might be right. A lot of times I actually think that they'll be wrong. The care is not as overly restrictive as the patient or the physician thinks it might be. But nobody wants the insurance company telling them, oh, you can't get X, Y, or Z. But that's the way Medicare Advantage works. So that's why we have to have an alternative to Medicare Advantage, so you can opt into fee-for-service, and that's fine, but then you don't get lower cost. You either have to pay for your own, or you don't get all those other things. And that's the trade-off. Oh, I do think there'll be a lot of trials, but the problem is they can never do enough trials to get all the care. And even once they do all the trials, the technology changes. So you say, oh, we really need this type of surgery. And they say, oh, the surgery doesn't work. Yeah, but now we can do it robotically. Then you need a new trial. It's very hard for the medical evidence to keep track because of the heterogeneity of patients, the continual technological advances. So I'm a huge fan of trials. I think we need, obviously I work at a place that does trials. But anyway, I'm a huge fan of trials and evidence. That's basically what people do. But I think it is a mistake to believe we'll ever do enough to make sure that we know exactly what the right standard should be all the time. That's kind of the core problem.
So what's the overhead of the Medicare Advantage programs? Because I'm aware that in other countries, the overhead costs are like 2-3% and all that. What is the overhead on the Medicare Advantage?
Yeah, I'll give you a 10% number. I don't know if that's exactly right. I'm not sure overhead's the word I would use. So a lot of the things that the Medicare Advantage plans do, contracting with physicians, doing this prior auth, all those things are fitting into, I think the word you're using is overhead, their profit margins. So there are rules called medical loss ratio rules, and there's ways to circumvent them. I don't want to get into that, although I'm happy to, I guess, later. But for the most part, the plan margins are going to be a few percentage points, and the Medicare loss ratio controls the total gap between medical spend and not, and that's probably around 15%. So you got a little ballparking north 10%. A lot of that stuff is the way in which they manage some of the other utilization and stuff. So, and by the way, I think they save money net. I personally believe they save money net of some of that. In other words, they wouldn't be doing prior auth if net prior auth didn't save money. But it is a more administratively complex system to have plans trying to limit the networks, trying to limit the utilization, and there's a bunch of other stuff they do. The big one, I guess, is the way the plans get distributed, the advertising, and you might think there's not as much value to those types of activities that the plans do, and I think that's possibly right. That's what happens if you want to rely on plans competing. If you have a competitive model of the world, which some of you may, some of you may not, I tend to be reasonably free market, but I think in healthcare you need a lot. The reason why it's the Healthcare Markets and Regulations Lab is because it's how you set the regulations to allow the markets to work. That was the basic theme. I don't know if it came through, but the core point here is if you have a competitive kind of system, you end up having a lot of these activities, marketing, broker fees, a bunch of stuff, and then all the stuff they do. But your point is right. It is multiples, a few multiples of what you would get in Medicare. So you could run a system much simpler if you just ran a government system. I wouldn't say the government manages everything well, by the way, but the point is they certainly manage it a lot cheaper if you just set fees and you pay them. It's just what happens is, because there's none of these other things, you have to worry a lot about excess utilization and a whole bunch of other stuff that goes on in the fee-for-service system. And that's the core trade-off between the systems. But the overhead of the Medicare Advantage plans goes into what their bids and stuff are. So they have to be able to outbid the fee-for-service system, even with their overhead. That's the way the system is basically designed. But it is more administratively complex, and it's annoying. Like, annoying is probably an understatement. It's really, really frustrating when you actually have to go through it. And by the way, there's also, in some states, in Massachusetts, we're protected, but in other states not. If you want to switch back, if you're in Medicare Advantage and you don't like it and you want to switch back, there's basically penalties. Penalty's not really the right word, but you can get underwritten and stuff, which makes it hard to switch back.
Thank you again for your presentation. I had a question about one of your slides. You showed that there were counties that had different, I forget what you said, 115 and 95% at some.
Yeah, actually, that wasn't on my slides, but I did say that.
Oh, sorry, I wasn't sure if
That's fine.
Yeah. So I was just curious how that works in terms of, I was trying to understand, is it that all the providers in that county are efficient and therefore some rates are set based on that?
So basically, yes.
And it made me wonder about like a metro county, like a rural versus urban. That was the
100%. So let's see if I can do this at loose, normal speaking speed. So originally there was a view in Medicare Advantage, which was counties would get paid 95% of fee for service. There was a bunch of problems with that system, but it was sort of even in a bunch of ways. And then the idea was if the plans could spend less than that, they could give the money back to beneficiaries, and that makes sense. The basic idea was plans will be more efficient than the government will be, despite the overhead. They'll take the savings, they'll give them back to beneficiaries, and all these other various things. That was the basic idea. And the thing is, I'm going to pick on some counties. I don't know if anyone knows people from these counties, or if anyone's Lime Street from these counties, you know where to reach me. But stereotypically, I'll pick Miami just because it makes sense, was a county that was a high spending county. And the idea was it was easy if you were a plan to save money in Miami, because again, there was so much waste. I'm not saying, just conceptual, so much waste, you could easily make money. And that money would go to beneficiaries in Miami. And then I'll pick another county, another city, just because of the letter, Minneapolis, right? Minneapolis being more efficient, and it's just an M thing, Miami, Minneapolis. You couldn't get as much efficiencies in Minneapolis because the delivery system in Minneapolis is more efficient than the delivery system in Miami. So beneficiaries in Miami got more benefits than beneficiaries in Minneapolis. And if you asked about urban-rural, beneficiaries in expensive urban places could have gotten more benefits than people in, say, Iowa, just to pick a state. And so what policymakers wanted to do was they wanted to equalize the availability of benefits. And so they basically said 115% of fee-for-service in the lowest spending, think most efficient, although we could debate, the lowest spending counties, and 95% of fee-for-service in the most expensive counties. So the cheaper counties got 115%, and what that does is if this was the slope, I don't know if I'm doing this right from where you're looking, but if there's a gradient from cheap to expensive, the payments bumped up the cheap, brought down the expensive, so the gradient was less. And that helped equalize the benefits across the places. And that was for policy motivations, because you didn't want people in the cities where the medical care system was very efficient not to have able to benefit from all of the aspects of the Medicare Advantage program. So that's why they did that. And that's how it played out. And anyway.
Hi, thank you for your presentation. My understanding of Medicare Advantage plans is that they are run by private insurance companies,
Yes.
such as Aetna,
Yes.
whatever, Humana, and they have stakeholders, right, stockholders.
Yeah.
And so they have to answer in the final analysis to their stockholders, which, in my mind, they're going to need to be for-profit, right, to satisfy the stockholders.
Okay, yes, they are for profit and they need to satisfy their stockholders. There are nonprofit MA plans, Blue Cross Blue Shield. But anyway, keep going.
Well,
But let's just focus on the for-profit ones, because I think it's going to be the gist of your question.
yeah. So I just, I'm historically, I've worked 30 years at a major hospital here
Yeah.
as a social worker in transplant. And I just have always had great difficulty thinking that healthcare is in the for-profit region. I think that there needs to be a way for healthcare to be available to all. And I realize there needs to be a small profit margin, right, to keep things going. But I don't think that we need to have stockholders involved.
Yeah, so I'll try and do this quickly. This is sort of the type of thing you want to sit around and talk about for an entire lunch. But I'll say a few basic things. Your basic premise that there's private sector in the American healthcare system is correct. I will say, and if I'm in Boston, there's a lot of nonprofits in Boston think Mass General Hospital. No one thinks Mass General Hospital is running at a pinnacle of efficiency in a whole range of ways. And so I think there's a core philosophical question about the role you think markets can play in driving efficiency. And you gave a narrative, which is not a bad narrative, that when you have money involved, people make decisions related to money, and you might not. That's problematic, and I completely understand why that can be problematic. But you also have for-profit entities that find some of these efficiencies that can do a bunch of other things. So if the American healthcare system was running great otherwise, if the fee-for-service government system was running at the level of efficiency it was, it wouldn't be managed care would have a much harder time out-competing it, if you will. And so this is just a core philosophical question about the role of for-profits and nonprofits, but don't assume that the nonprofits are all angels or that the for-profits are all devils. There is challenges on both sides, in a bunch of ways. And while it is certainly true that plans need to respond to stockholders, they also need to compete for beneficiaries. And again, I believe, as I said before, we need regulations to prevent the most egregious problems. So there's network adequacy rules. We need a whole slew of regulations to manage that type of behavior. But the question at the end of the day, and I'll leave it for y'all to ponder, is what role, if we need efficiency, what role will markets and private sector play in generating that efficiency versus for-profit versus nonprofits? And remember, a lot of this started because of widespread variation in the practice of medicine, because there wasn't any system controlling how it plays out. And I guess the last thing I'll say in this, and so I've been in MedPAC for 6 years, and I was off for 6 years, now I'm back on for 6 more years. The first thing you realize at MedPAC, and I love MedPAC, is all the flaws in how the government runs systems. So don't assume that the best version of government will probably beat the real version of markets. The best version of markets will beat the real version of government. We're comparing two very imperfect systems and two imperfect regulatory systems, and how we get that balance right is really what matters. So I understand that there's a lot of for-profit frustration, and maybe justifiably, but I think you could find that in a bunch of other organizations too.
Everything you said screams out for a universal health care system. You mentioned 5 basic payment mechanisms, but in fact, within those, there are thousands of inscrutable plans that nobody understands except maybe you. And even with Medicare, it's sort of ridiculous. I get my quarterly statement and say I had an operation. It says your doctor charged $5,000 for this. Medicaid paid $500. Your private supplement paid $50, and you owe 26 cents. So it's just inscrutable and almost impossible to work with. So what about the universal health insurance eventually?
Yeah, I think so. The short version is I'll say 2 things. The first thing is the devil's in the details of what that means. And an enormous amount of that depends on how well you think the government would run that system. So what most people, you could have a universal system. You could have Medicare Advantage for all. You could have a system where everybody gets coverage, but they're all run through a bunch of private plans. There's places, Switzerland will do a version like that. Usually what people mean when they ask that question is what you would have heard in the Medicare for All debate, which was we're just going to run the Medicare program or get rid of the private plans, get rid of all the, usually the words middlemen, some version of that word, and the government's just going to pay for everybody. That's usually what, and everyone's going to, that's the way it's going to work. And that's not, that's a reasonable view. People have that view. The poor question is how well you think the government would ultimately run that system. And what you think the prices would, remember, we're talking about a system where the prices for physician services in the government-run system have gone down 1% a year relative to inflation for the past 30 years, right? So it's not the case that I could probably spend my entire rest of the time here telling you things the government does that's just crazy. And usually the response is, sure, they should do a better job. And you want to know something? I agree. Half of my life is, yes, you should do a better job. You should execute better, absolutely. But there's a question about how well the government fundamentally would do that. Do you want the government controlling all of these various things? Because the government will have, because they're paying, various cost containment activities about what happens. The advantage of our system, whether you like it or not, is it gives a lot more flexibility and a lot more ways for people to choose, right? But that system creates all of the problems that you said. We can't choose, it's crazy, there's a ton of overhead in getting it to work. I don't know, the billing stuff is crazy. So my personal view, and again, this is a markets regulations thing, is we need a lot more standardization, a lot more control of the bounds around how this competition in markets work, right? But I am personally skeptical of how the government would run the system. And a lot of this depends on who you think. So again, in my world, the people that wanted Medicare for all, they not only wanted Medicare for all, they had a vision of the people that were running it and what those people's motivations were. But it turns out the people that are running it might not be those people, and they might not have those motivations. And now you're in a system where the government decides whatever it is you think they decide, and you're stuck. At least in our current system, for better or worse, you could opt into some other aspect of things with a lot more flexibility. So there are real advantages to simplifying the system. I was asked in another talk, if you could do one thing, what would you do for the American healthcare system? My big answer is simplify. Just simplify. And that requires limits, so standardizing certain things. It's just, we have way too much complexity in the system, and it drives everybody crazy for a whole bunch of reasons. But we don't need to go all the way to throwing it out to get there, because, and again, it's not crazy to want that, but understand you have to believe once you give some organization universal coverage, think about other countries, that the government then controls all these things about the healthcare system. And that may be fine. I'm not going to take a position on that, but it might not be. We could divide up the room and have like a little caucus to see where people are on that. But that's the core question: is how well you think it will be executed.
Probably something that the other speakers might address also, but you've used a word a number of times: waste, discounting fraud out of the system, which there's plenty of. Where do you see the biggest opportunity for waste?
Okay, so Rena's here. I don't know if she's going to talk about this. So Rena, I'm sorry. Skin substitutes. Let's just talk about them now. Sepsis coding. There's just a ton. There's a widespread analysis about how people are getting care across the country in a range of ways, and it's widely variable. So I picked skin substitutes because that's what's in the news now, and again, Rena might talk about it. But the issue is you could talk about imaging procedures, unnecessary vascularizations. I'm an economist, so what I'm about to say I'm not really clinically qualified to say. We have a lot of body parts. I can name about 1/3 of the body parts. Almost all of your body parts can break. It just turns out that's a function of body parts. And they can break in a bunch of different ways. And they can run a bunch of tests, full body scanning tests. You can debate if they're wasteful or not. There's a whole bunch of these types of things. And the issue is the services are often good for some people, not for other people. And what tends to happen is the use of services, in part because of incentives, in part because of culture in a bunch of ways, the use of services expands often beyond the subset of patients who should get various aspects of services. And so it's very hard to say in a very specific way, this is all wasteful, because it turns out to be very nuanced about, it's not that we should not get revascularizations, heart procedures. We should, but not everybody should get them. Or if you get them, we should get 2 stents, not 8 stents. Or not everyone should get back surgery. Some people might need back surgery. A lot of people get back surgery that maybe don't need back surgery. There's just a range of these types of diagnostic test workups. My son had a disease a condition called Osgood-Schlatters. It's a growing thing when you're an athlete, and the pediatrician said, you have Osgood-Schlatters. Wait 6 weeks, you'll get better. But he didn't want to wait, so we went to MGH. We got the doctor there, who was an orthopedist, so we paid much more, said you have Osgood-Schlatters, but you need an MRI. We got the MRI. The MRI was wasteful. Oh, and then he said you'll get better in 6 weeks. And there's just a lot of this type of imaging and stuff that happens in a range of ways that is micro, that's hard to get out in a very, we did a trial, you shouldn't do this. Back to the very first question, which I think is right. Medicine is very complicated, and you know why? Because bodies are very complicated. And it's very hard, it's very personal. Right? It's very hard to know how to practice medicine. When I work around a lot of doctors, it's amazing. They do all the stuff I do, and then they actually know a gazillion more stuff. Now when you get to my age, it's good to know a lot of doctors. But that's the challenge, and that's the advantage of these incentive-based systems. You don't have to go in and micromanage who gets what when. But you worry that Medicare Advantage plans or for-profit plans are denying things when really they should get them. So I think we need to focus on that really abusive type of activities. But it's hard to give a specific answer. Oh, I think I'm done.
No, I get to ask questions.
Oh, they're waving.
No, I'm the timekeeper.
Oh, good. No, time's just fine for me. I think I've been talking now for 2 minutes. Go on.
Yeah.
So I want to ask it from a different perspective. I am a Medicare consumer, and I'm the one who receives the service, and I want to be around for a long time. So here's my question. As we're going through, we're getting more tools to be I'm an economist and an accountant. And I don't like that I go down and I sit in a chair and a physician is going to tell me A, B, C, D, E, F, G. You do what I say, you jump this hoop, and it's going to be good. So I'm a type 2 diabetic, and I said, I can't take it anymore. I've got to fix this problem. The endocrinologist tells me to do this, my nutritionist tells us to do this, and then I said, wait a minute, I need a little bit more. It's not working. So I'm creating curves with AI that tells me a predictive model by using a 24-hour monitoring of my glucose, everything I eat, what's going to happen. And the models are getting closer. But at the same time, I'm taking the shocks of, I have to take this medication. Where does it give me a bump? And now I'm going back to my physician and I'm saying, physician, wait a minute. This one is causing me a bump. Why do we need this? And so more and more people, I'm just an average person, more and more people as informed consumers are going back to our physicians and saying, wait a minute, is this really the best thing? Can we do this? Second question would be, hey, Medicare does not pay for 24-hour monitoring because they say a type 2 diabetic shouldn't have it. So I said, forget you, I'll pay it for myself, I'll build my own curves, and you know what? I'll make my model free for anyone. How do you see consumers knowing more and challenging our physicians? What will it happen to Medicare, and will it actually bring the prices down?
This might be an unpopular answer, but first let me say, you're not an average person. I go to a lot of places. Anyone that asks that question is above average. So we'll just leave that there if the audience can decide. So I think consumerism is important in general. I think information is important. I think AI can enable us to get a lot better information and be more active consumers. So in that sense, I'm quite positive on doing that. And certainly in conditions like diabetes, because of its chronic nature and because of the specific numbers that you can measure in diabetes, I know of a company doing this for congestive heart failure, which turns out to be harder for a bunch of clinical reasons. But I think when you can activate consumers, in general, the world can be a better place. Although you have to be wary that you gave a story where in a very altruistic way, and I say that because you said give away for free, that's the definition of altruism, you've built a model to help consumers. But there's a lot of people building models to do a lot of things, to get a lot of people to do stuff that might not have quite the same set of motives to get people to be active consumers to get X, Y, or Z. And if you look at a whole bunch of advertising or other things going on, the world of activating consumers isn't all as positive as your question loosely implied. I think given the world of new information, like always, it is a double-edged sword. In general, it's a good thing. It's a much better world to have consumers engaged in their healthcare and understand, and clearly you know, and you can in diabetes, figure out all these markers and what's going on, and 100%. I think that if consumers are really thoughtful about their health, I think that's that's broadly speaking a good thing. But there's a lot of people that want a lot of things that don't really work, or someone's told them that doesn't really work, or they're demanding antibiotics for a viral infection, or someone's told them if you do this, it's going to be great. And so there is I, by and large, think we're going to be in a world with more activated consumers, which is a mixed blessing if you're a provider system, because you got to do all these people coming in demanding something that you know is not going to work for a whole bunch of reasons, or they want hope where there's not really probably hope in a bunch of ways. And so I think we're going to need to work through a delivery system. And what I liked about your question and point is, we could debate whether or not Medicare should or shouldn't pay for glucose monitors for type 2 diabetes. But the point to your question is, you have the means to say, you know what, this is what I'm going to do, I'm going to pay. And my general view in that sense is more power to you. But we, because of our fiscal problems and other problems, have to decide, what have we collectively decided to pay for everybody that's, everybody, even in this room, everyone's going to have different tastes about what to do. And they're going to have different tastes about wanting to be engaged. My mother-in-law, who passed away from cancer, she did not want to engage in her care treatment for a whole bunch of reasons. She wanted to go and she would say, I just want the doctor to tell me X, Y, and Z, and that's what I'm going to do, because I don't want to spend my time sorting out what to do in my condition. So just people differ. And I like a system where someone who's actively wants to manage their disease has the means to do it, and you have the means to pay for the extra stuff. But I think you have to be careful about having Medicare in a system where they pay for what everybody wants in a whole bunch of ways based on what the trials. And does Medicare get it right all the time? Surely not. But when we talked about the Alzheimer's drugs would be a perfect example of where, again, Rena can talk about Alzheimer's drugs, but where the evidence was such and the demand was somewhere else, and you have to figure out where you're going to get in the bounds of who gets access to what the government will pay for. That's a complicated question. And it's really hard to make in a government setting because not everybody's going to like what you do no matter what you do. Oh, I didn't get Vivian's question. You'll have to email it to me. Thank you all very much. I took water, so whoever's speaking next needs their water.
Thanks very much, Mike. That was really terrific. Probably you couldn't tell because of the type, but a lot of the graphics, the figures, and the numbers come from MedPAC report. So, that's a terrific resource to go to look up some of these numbers and just read thoughts in terms of improving the quality of Medicare delivery of care and costs. And again, as you can see, that a lot of that is Dr. Chernew's input into that organization. So the next speaker we have is Dr. Ben Handel from University of California, Berkeley, where he's a professor. He's also a co-director of the Gilbert Center at Berkeley and the co-director of the National Bureau of Economic Research Insurance Working Group. So all health economists know Ben for, he's just over the years contributed terrific amounts of knowledge in terms of how commercial health insurance works, both in terms of consumer behavior and in terms of how the insurers behave. But then also, any listeners to Freakonomics? If you listen to that podcast, you would have noticed that Ben was on a recent episode and he kind of ventures more broadly in terms of all these particular issues, talking about sludge. And he's even going to go more broader than that today, talking about AI in healthcare. So with that, Ben.
Okay, thank you. As Mike mentioned, I especially want to thank the Baker Institute and thank Vivian. This is a really nice opportunity to get to come here and speak with all of you. And while I have quite a bit to talk about in the space of AI and healthcare delivery, I'm also very excited for your questions. That's actually the part of these talks that I enjoy the most sometimes, rather than listening to the stuff I created already. So please think of your questions, and I'm excited to hear them. So Mike touched on a number of these issues already, and hopefully my talk will give you kind of some more thoughts related to the issues of AI and the shifting landscape of healthcare markets, and just give us a sense of kind of what are some of the key issues that we might face, whether from a social or regulatory standpoint, going forward. And I want to give a disclaimer up front, which is that, not unlike other people from the San Francisco and from the Bay Area, AI here, it's a little bit of a red herring just to get you to be interested in the talk about healthcare and incentives in healthcare. I just want to be clear about that up front. I do work with AI tools and know about them. However, as Mike mentioned in his talk, I actually think that in a way you can think about AI as information, of course, and you can think about more information and greater access to tools as reducing frictions in some way in the healthcare system. And so then what I want to talk about here is, what will the impact of reducing these frictions be? But I also want to talk about what could the impact be in the sense that different participants in the healthcare system, whether it's consumers, but especially firms like insurers or providers, they don't always have the incentive to adopt tools that remove frictions from the system, that make it a seamless, hassle-free environment, as Mike was just talking about. So a lot of the discussion here is going to be about what could be possible with tools like this, and then why might, from a regulatory standpoint, what are some of the themes we might want to pay attention to actually leverage some of the benefits from these tools? Okay, and the one thing I want to underscore as we go into this is, as Mike mentioned, healthcare is extremely complicated, and so as a result of that, and you see this a lot in companies that are being built now and worked on. Healthcare is a really fantastic space for AI and AI tools. There's so much information, and there's so much information that really isn't being used in care, in informing consumers, as we were just talking about. And so there's a huge amount of potential here. But to leverage that potential, I think it's incredibly important to think about the incentives of the different actors. So you see here insurers, providers, policymakers, consumers. I hope to touch on each of these issues through the talk today. So I have 4 themes I want to touch on. And if I don't dive into one of these as much as you're actually interested in, feel free to follow up in your questions. So the 4 themes I want to talk about are, and I view these as actually in some ways going from less complicated from a researcher or policymaker standpoint to more complicated, are consumer choice of insurance plans, which is an important facet of the healthcare system in the US, consumer use of insurance, so how do people use their insurance plans once they have them? How do insurers interact with doctors, which I think is an incredibly important issue? And then you go to the doctor, you're receiving care. What are the possibilities for tools to actually improve that care? Just forgetting about the insurer, forgetting about kind of everything else that's kind of going on. And I think all of these are important issues. Obviously, we're going to cover these at a fairly high level, which is why I'm particularly interested in your questions. Each of these topics could, in and of itself, be like almost a whole course, right? So these are big topics. So with insurance choice, I want to take a step back. This is an area where I feel like there's actually quite a lot of evidence in the academic literature and in the policy literatures on insurance choice, and more specifically, are consumers good at making insurance choices? And good, what I mean, but I don't mean are consumers good at actually like thinking about it and searching through options. Consumers are obviously doing the best they can in a very complicated system. But the outcome of those choices is often clearly, in some sense, not good for consumers when you think about kind of the value they're getting out of the choices they make. So the chart here, it's from a case study that I worked on now a while ago, about 15 years ago, that studies employees at a large firm with approximately 10,000 employees. And like many of you who have had coverage through your employers, this employer offered access to multiple different plans. And these plans are complicated, right? You go look at your open enrollment book and your eyes start to glaze over, you start to kind of fall asleep, and then you realize, wait, this is important. I actually want to try and make a good choice. And so what was the case at this firm, and you don't have to understand the chart to understand what I'm about to say, is that some options that consumers could choose were what I call dominated by other options. What does that mean? That means in one option, you can get access to exactly the same doctors, exactly the same restrictions, pretty much literally the exact same insurance administrator, so the same insurer. But the cost-sharing features are different. So all that stuff you read about in the booklets, deductibles, co-payments, co-insurance, these were the differences between the options people were choosing between. The way the premiums and these cost-sharing features evolved, in one of the options, consumers, regardless of their health status, whether they're sick, healthy, whatever you want to do healthcare-wise, they were losing money relative to being in the other option. This is what dominated means. And so what this chart shows is that for any kind of expected, for any actual health spending you have, where health spending is on the x-axis, what you're actually going to pay, including premiums and health expenses, is going to be at least $1,000 bigger in one plan versus the other plan, and in some cases more than $1,000 bigger. So the reason I like this case study, and the reason economists take to case studies like this, is it can be really hard to say when is a consumer making a mistake, when is a consumer not making a mistake. These are cases where it's pretty clear that ex post consumers, or after the fact, consumers are worse off in a plan where you get the same health care, but you're losing at least $1,000 or more, right? And what I talk about in the paper is that, this is all sorts of people making these choices, right? It's people who are well off and well educated. It's people who have lower income and families who could really, clearly have a big high value of the extra money. And so then if we kind of go from this case study and we step back into the broader literature, there's now many, many, many studies that kind of show the difficulty in choosing insurance plans, okay? These studies cover the range of markets. It covers Medicare Part D, it covers Medicare Advantage, it covers employer markets. And so this is now what I would think of as kind of a fairly robust set of facts. And then the question is, well, what are some things we can do about it? And how might AI kind of weave itself in to this process, okay? So about 10 years ago, I worked on a paper for the Brookings Institute where we tried to think about kind of what are some possible policy solutions for these issues, okay? People talk about information provision to consumers, where studies show there's some benefit, but it's hard to get people to engage nonetheless. What we talked about from a policy standpoint is something we called smart default options, where what a default option means is you as a consumer don't really have to engage with the choice. Someone else, either another firm or a policymaker, is adopting an algorithm that helps you make the choice, or basically gives you, like, has an option for you as a default, and then you can move away from that option if you want to later. So the benefit of this is that in economics across a variety of products, insurance, 401k plans, many areas, default options are very powerful, right? If you have something as a default, you don't have to do anything, you have that option, people often stick with that, okay? And so what we worked on here is we worked on kind of what's a way you could do this kind of as an algorithm in a broad sense. And the key thing about healthcare markets is that there's access to lots of data for consumers. And if you can integrate consumer data into a flow where you both look for financial value that a product is delivering and ensure access to healthcare for consumers, for example, their existing providers or other things that they would obviously care about in the product space, then you can have a smart algorithm or a smart default option that actually switches consumers across options if their current option they chose clearly is worse than another option in, like, kind of measurable ways. And so what are some of the, whoops, wrong way. Sorry. I can't figure out how to make this go backwards. Sorry. I pressed both buttons. Thank you. Back one more, please. Thank you. And so one of the key difficulties here that I want to talk about in this space is the difficulty of data integration in the healthcare space, okay? Sorry. Okay. Can you please go forward to slide 8? Thanks. And so one of the key issues in the healthcare space with these kind of default options is data access. So, and this is a key issue for AI tools in general. The more free access to data is, or the more free-flowing, I should say, access to data is, the greater opportunities there are for AI tools and algorithms like smart defaults to have an impact, okay? So another way to say this is that real-time custom data integration is crucial for improving individual choices of the kind we were just talking about. Now, this has a couple issues. So first, you might ask the question, well, why aren't things like this in place already to a large extent in a pervasive way? There's two key reasons I think of. One is that employers who are often providing insurance, or Medicare Part D, who's has different constituents it appeals to, they have incentives, especially with private firms, to hold on to proprietary data, okay? And so does an insurer, say you're enrolled in big insurer, pick your favorite big insurer, do they really want to share their data with other big insurers, right? Do they want to share your claims data? Do they want to share the data that could help a centralized algorithm help you make a better choice? The answer is no, right? They're using that data for proprietary reasons and reasons that are productive, but nonetheless siloed off and proprietary. Another reason why data access is difficult is individuals don't like the idea often of a centralized agency or their employer really using their very detailed health data for reasons that are related to insurance choice, but not really related to healthcare provision, right? This isn't your doctors using your healthcare data. It's an algorithm or your employer. And so these are two barriers to data access. And this is a policy area, especially on the first dimension related to holding proprietary data, where policy can have a big impact. The more regulation you can have that kind of silos and moves this kind of data, or moves it from silos into a centralized place where you can kind of really seed these algorithms, the better these kinds of algorithms will be able to work and help consumers. Okay, can I go to the next slide? Okay, now I want to move on, which is closer to something that is closer to what Mike was talking about, which is consumer use of insurance. And I want to give 3 examples here when I think about the potential for technology. And by consumer use of insurance here, what I mean is now we're out of the zone where you chose your health insurance plan, whether in Medicare or your employer, and now we're thinking about you are trying to go receive health care. What are the barriers you're facing? Okay? And so I have 3 examples where I think this is clearly lacking, I would say right now. The first is you're searching for a medical provider. So how many of you have had the experience where you're searching for a provider and you can't find the provider you want, or they have a 5-month delay? Okay, a good amount of you, right? And this is very common, yet if you go look for a provider, it's very cumbersome, as you know. You often end up having to call them yourself. They say, well, maybe we can get you in 2.5 months. And then you end up having to exert lots of effort in order to get an appointment that seems like it should be something that you should just get in a much more frictionless way. This is a huge problem in mental health care where this chart applies, and the term is ghost networks. But this is a broader issue. And so here, this is this is in some ways like not really an AI point, even though AI tools can shine the light on this in some sense a little bit more. But think about all the complexity that platforms that you engage with in your life provide. So think about, retailers like Amazon or Walmart or Airbnb. I mean, these companies are developing very complicated platforms that are arranging, buyers and sellers and everybody together. And your experience in those cases is almost seamless. And the reason it's almost seamless is these platforms have a financial incentive to make this experience seamless, right? They don't even want you to think before you click buy, right? Insurance is the opposite. They in a lot of cases, they really don't want you to buy unless it's absolutely necessary. And so this is a case where regulation paired with AI that really helps kind of synthesize information into, for a given insurer, who are the doctors in your network? What are their wait times? What are the services they can provide? That seems like a simple thing that should be able to be offered. And it also seems like the kind of thing that regulation, at least raising a floor for kind of availability of this information, is important. The reason it's clear that's important is this should be happening already. Tools that kind of source this information can just make this product better. Let's make sure that those tools are able to make it to the market and see the light of day with insurers. Can we go to the next slide? Okay, what's the next example? The next example is prior authorization, step therapy, coverage denials, which we were talking about as well in Mike's talk. And here, kind of very simple questions are, when you think about these kinds of issues and these issues when kind of on your path to receiving care, first, as a consumer, do you have any idea whether your insurance plan is actually going to cover these things? Do you have any idea of the requirements for covering these things? And then probably more importantly, does your doctor know, right? And then if you take it a step even further, say your doctor is extremely well informed about prior authorization requirements for every different insurer, the insurer is still often incentivized to not make the process as seamless or frictionless as possible. And the reason is they want to make sure that when people receive a service or ask for a service, that they really need it, right? And so this is what I refer to as kind of decentralized or ordeal-based rationing, where all healthcare systems have some form of rationing. In the US, especially, prior authorization, step therapy, coverage denials are ways that rationing happens. And I'll return to this in a minute. Here, there's a clear opportunity for more standardized protocols, okay? While we want insurers to have flexibility in terms of what are their coverage requirements and what are their processes for rationing care, it is possible to make those processes and the data exchanges involved in those processes more seamless and more frictionless. Can we move to the next slide? Okay, the last point I'll bring up here is how much does something cost? Sounds really simple. What is the price for the service that you're going to receive? And this, for many of you who have received complex healthcare or even basic healthcare, when you go to the doctor, you have no idea how much something is going to cost. Now, there's research that's shown that even with more transparent prices, consumer responses aren't particularly great in terms of using that information to make very informed choices. Nonetheless, I still think there's a benefit for having more transparency in the system. Now, there have been a number of regulations that move us in this direction. However, still those regulations in some way don't really make it to the consumer. If you're asking the question, I want to go get this procedure, how much does this actually cost? I think a caveat here is price transparency like this is unlikely to be a panacea unless it's paired with kind of also very strong health advice from a doctor in different ways. However, the reason I bring this up here is tools that are able to source this price information from data could really do a much better job than even existing transparency tools in giving a specific individual a cost estimate for the care they're going to receive. Okay? Can we go to the next slide? Okay, so AI has a lot of promise. These are examples where AI can help. This sounds easy, right? Or at least kind of easy. What's the problem? Okay. One of the issues here is the incentives that an insurance company has, and not just insurance companies, others in the system have, related to having the system be a more frictionless system. Okay? And so the question here is, do insurers want consumers to more frictionlessly or more seamlessly be able to find providers, right? Do they want example one paired with AI? That's like making this a really easy process. Well, this is a complicated answer, right? And what's going to happen? That would lead to finding doctors faster. That's going to lead to more healthcare. And more healthcare is generally for insurers going to lead to lower profits. Okay? Consumers are going to be happier if consumers want healthcare, or if they're consuming healthcare. That's a plus for insurers if consumers are happier. But a minus is that premiums are going to be higher. Because when everyone in the room spends more on healthcare, or half the people in the room who are sick spend more on healthcare, then everyone pays higher premiums, even the people who are healthy. Okay? What happens when the healthier people pay more premiums? What happens is, or have to pay more premiums in a plan. What happens is they go choose another plan because they say, well, we don't need to choose this plan with higher premiums. We can choose the cheap plan with lower premiums. Okay? Then what happens if only sick people are choosing a health plan? The premiums go up even further. This is what's called adverse selection in the healthcare system. And when the premiums go up even further, at some point, this insurer has a bad business model, okay? And it goes out of business. And so what happens, what you need for a more frictionless system, where friction is the key ingredient in rationing, is you need somehow regulation that raises the floor, that kind of helps us reduce the frictions in the system. Then you want the implicit constraints, so the rationing that happens through all this confusing mess of requirements, you want those to become more explicit, right? That's basically what will happen. Instead of searching 4 months to find a doctor, they're just going to tell you, you have to wait 4 months to see a doctor, okay? And whether that's better or worse depends on your perspective. Okay, can we go to the next slide? Okay, and so then to kind of wrap up this section, I think this is a really important question, and Mike touched on this as well, which is, are insurers the bad guys here, okay? And I actually think, I know this is unpopular, I think, but I think the answer is no. And the reason I think the answer is no relates to the last slide that I was just talking about, right? If, say, insurers give you everything you want, everything's frictionless, full deployment of AI, they're not your insurer anymore. They're out of business in 2 years, right? That's a bad business model for them. And it's a bad business model because of the way regulation in the system is set up, okay? And so one way I think about this is, I'm not, insurers obviously do stuff that we don't like, okay? That's inevitable in a large business world. I think that goes without saying. But a lot of the reasons for the frictions and the hassle and the confusion is the way the system is regulated. Not that insurers per se are saying this is the way we want the system to be, per se, at a high level. Okay? Can we move to the next slide? And so I think one way to think about this, to kind of wrap up this in the context of broader policy questions and rationing, is imagine we have access to these tools, to AI tools. We regulate, insurers have to use these tools. This is great. All of a sudden, you can find your doctor really quickly. You know what the wait times are. Prior authorization, super clear. Awesome, okay? We still don't want people to pay for all of their healthcare. Healthcare is super expensive, and it's hard for people to afford, but we want people to have access to healthcare. So we remove all this stuff that's rationing healthcare right now, right? Hard to find doctors, hassle costs, prior authorization, ordeals. We're going to switch to one of these other rationing buckets, okay? Because prices are not what we want to use all the time in healthcare. And so here are 5 buckets, and you see these buckets from kind of different national health systems in the US. National health systems around the world. There's price rationing, which we don't want to always use. There's decentralized type procedures, so utilization review, denials, hard to access doctors. This is heavily used in the US system as a way to ration healthcare. There's gatekeeping, which means your primary care doctor has to give you permission to go to other doctors and manage your care. There are lines where, like I said, if you're in Canada or other healthcare systems, they say, this is great, you can receive healthcare, but you have to wait for 4 months. And there's health technology assessment, which just means we as a society make a list, this stuff is valuable, this stuff is not valuable, you can only do the valuable stuff, okay? And the point I want to make, which is I hope you can take away from this, is that any healthcare system, more or less, in a society where resources are constrained, which is all societies right now, is any healthcare system has to be a combination of weights on these buckets. Okay, you're going to be saying, okay, we want tons of lines, let's forget about prior authorization. Or we want lots of price rationing and we don't want to insure people a lot, but we're not going to have lines. But I want you to have in mind that you are choosing from weights on these buckets, okay? And I think that's an important point to make when you think about comparing the US system to other systems. Okay, and as I mentioned, I think that tools, regulation that really kind of raises the floor for technology in the system, what that can do is, or what that will do if you go back 2 slides, is that will basically take us from the bucket of decentralized and hassle rationing to a world where we're having more explicit rationing. So lines, gatekeeping, health technology assessment. Okay, I think I have 10 more minutes. Okay, great. Let me talk about insurer interactions with doctors. So this, of course, is a twin of insurer interactions with consumers, because consumers and doctors kind of consume healthcare as a pair. But I want to make a slightly different point here, which is from a physician perspective. So the last section was really from a consumer perspective. From a physician perspective, physician hassle, physician burnout, you can open whatever publication you like to read and you're going to see articles on this, okay? Being a physician, it's not very easy now, okay? And not easy from the perspective of providing healthcare. It's not easy because you are dealing with so much administration, so much paperwork, so much back and forth with insurers, so much in terms of data processing and data overload, okay? And so there's lots of articles you can find talking about physicians with burnout, okay? There's ways to improve this that technology can help with. You can have automated real-time claims and verification of claims that kind of reduces a lot of the kind of interaction between insurers and doctors. You can have streamlined prior authorization interface, where of course there's companies trying to work on this and regulators trying to work on this. You can have improved data flow to patients so that doctors don't have to spend time on the phone, or their offices have to spend time on the phone talking to patients. And so the question is, well, do insurers want to reduce the frictions in these interactions and make them more seamless? This is a very complicated question, even in the doctor space, that I'm not going to even try to fully answer today. But I do want to make the point here that this does relate to whether doctors are integrated with the insurer, so part of the insurance broader business, or not, or are they more independent physicians, okay? And the incentives here can be very, very different in terms of what's the kind of, how seamless do you want to make this, okay? If you're forming other policies, so health technology, care provision policies, as you are with your integrated doctors, you may want to make this process more seamless. If you don't have the access to these kinds of explicit rationing technologies, as with non-integrated doctors, you may not want to deploy these kinds of tools, okay? And in this section, I have a number of charts, but kind of the main point that I really want to make here is the way the physician workflow has evolved, or the way the physician provider job has evolved, it makes it very hard to be an independent physician, right? And so what you've seen over time, which this chart shows, is a decline in independent physicians. That's the black line here. And you've seen an increase in physicians that are owned by a hospital or owned by another corporation. Here, importantly, another corporation usually either means private equity, which is, most of these corporate-owned physicians, of acquired physicians, or health insurers. And these trends are continuing. These are very strong trends that, because of issues like hassle, burnout, negotiating with insurers, doctors feel immense pressure to join broader corporate organizations. Okay, and this nice chart shows kind of a variety of the reasons why doctors felt they needed to join, or why they decided to join a larger practice or a corporation. They need to better negotiate higher payment rates with payers, and it's very hard to do that if you're just one doctor or a small practice. they need to better manage payer requirements and administrative requirements. 60% of doctors say that's important or very important. And so, in some sense, when doctors go to join a big company, whether it's an insurer, a private equity group or whatever, they're basically saying, we want to be doctors again, right? We don't want to be administrators. And I think that's kind of a very important thing to keep in mind as we think about how can technology impact the provider experience, and then what are the downstream implications of providers able to have more of their independence in terms of dealing with these hassle costs or dealing with payment rate negotiation. And I think that kind of the trade-off here, if you think about it from a physician standpoint, it's really, do we want to join kind of a corporation, and then whether it's from the insurer or the private equity group, starting to shift our care in the direction that their incentives imply we should shift our care, or do we want to deal with the high hassle costs that come from not being in an organization like this? And I think that this is kind of an important trade-off doctors face now and providers, that conceptually IT tools and AI especially can help make this not feel like a choice that has to be made if you want. So, in this space, the kind of policy solutions are, again, raising the floor for tools, ensuring that providers can have access to tools like this. And there's already been regulation, of course, moving in this direction. So there's CMS interoperability and prior authorization final rule, which is already working to streamline provider access, APIs, prior authorization tools to kind of make it more standardized, make sure prior authorization is electronic rather than being kind of done in kind of 20th century ways. And I guess that's why part of the act, one of the acts is called the 21st Century Cures Act, okay? Okay, I'm gonna close with 5 minutes actually on a more provider-focused or a care-focused perspective. So far, the way I've talked about the deployment of AI or technology is really relating to insurers, consumers' choice of insurance, use of insurance, or insurers and doctors interacting with one another. I have recent research that really tries to focus in on just the care process, the process of care provision. And I want to kind of put this in the context of the broader econ literature, which Mike also mentioned, which is that there's a long literature now that very clearly and cleverly documents what is called practice variations in healthcare. That just means, as Mike said, if you have a doctor in Houston and the same kind of doctor in Buffalo, those doctors are often doing different things, spending different amounts of money on things, and this is a pretty robust finding in the literature at this point, okay? So the paper, the research I've been working on lately that we're hoping to actually pair and integrate with AI tools, it uses data, very detailed data on, I would just describe it as everything that's happening in the emergency room or the emergency department at the University of California, San Francisco, which is a large teaching hospital. So think of it as a large academic teaching hospital. Okay, and in this study, it covers 3 years and approximately 100,000 patients, okay? And the question in this study that we're asking is, what's the impact of medical provider cognitive load on patient care, okay? And so cognitive load, it sounds kind of like a fancy term. All I mean by that is you're tired because you did a lot of stuff. And did a lot of stuff as a doctor in the emergency department means today was a tough day. You had a lot of patients who came in, and these were very complicated patients, potentially, okay? And very stressful, okay? So what the chart on the right shows is that based on the way we generate measures with kind of tools from machine learning, cognitive load for doctors in the emergency department, it varies substantially over the course of 3 years. And so over the course of 3 years, just take the same doctor, so take Vivian. Vivian's now a doctor in the emergency department. Sometimes she has an easy day, not too many patients. Some days she has a super hard day, very tough. And all this chart is showing is that there's a lot of variation in that, okay? And so then we look at, can you go back one slide? We look at, the other way. Other way. Uh-oh, I hope you're not having the same problem mine is having. Yeah, there we go. No, one more back, sorry. You can leave it here. I'll just tell you the results. So the first chart, which we can't seem to get back to, looks at process of care changes as a result of cognitive load. So the last chart, what it does is it says, when you're more tired, when you're more cognitively loaded, what do you do as a physician in the emergency department? For the exact same kind of patient, everything the same, like on this patient coming into the hospital, you're likely to provide more orders and more tests when you're more tired. And those tests are much less precisely targeted towards the actual treatment, towards the actual final diagnosis of the patient. And so basically, when you're tired, you're doing more stuff, but the stuff is more scattershot. It's kind of like throwing stuff at the wall. Then you go by kind of all these other parts of the paper and all of these other things we're doing in the paper. A final chart we look at is then, what is the downstream impact of these variations in provider cognitive load on admission to inpatient in the hospital, okay? Here, cognitive load decile on the x-axis. Just basically, if you go to the left here, you're not tired and fatigued. If you go to the right, you're super tired, like it's a tough day, right? And what we find is that when you're most cognitively loaded, so when you're most tired, you're 25% more likely to admit a patient to the hospital from the emergency department, holding all other things equal, like we're talking the same exact kind of patients. And so what that means is as a physician, you're tired, you're having a harder time precisely targeting what's wrong. And so when you're cognitively loaded, you say, well, we're not sure we're going to admit this person to the hospital. And of course, when you're admitted, that means you're in the hospital for longer, it means you're spending more money, etc. So these kinds of within doctor changes in behavior that come when you're tired, these are things that clearly there's potential for AI to help with, and there's lots of kind of AI-focused companies working on now. And the goals here, I'll just kind of underscore two things, and then I'm going to wrap up, are that people are developing tools that really are using very granular real-time data to mimic other physicians. So a physician might have a tool that gives them alerts that say, whoa, what you're doing for care for this patient in the emergency department, that's not what people would typically do. Are you sure you want to do this? Okay? Another tool, another version of this, which I think is quite interesting, is tools that allow physicians to better mimic the best version of themselves, right? Because one physician may not want to practice the same way as another physician, but they might want to practice like the best version of themselves when they're not tired. And so tools that are being developed now are very sophisticated and using this kind of data. And so this is something that I think will kind of more naturally be adopted by hospitals and doctors. And I think this is a place where there's just a lot of promise in AI and not as much of an issue in terms of the frictions of adopting. I think the frictions of adopting these kinds of tools are really just fears that organizations have for integrating granular data into algorithms, which are reasonable fears. Okay, so let me just kind of quickly wrap up and then get your questions. The long story short here is that there's a huge amount of promise. Obviously, AI, if you pair it with kind of very powerful data sets, can deliver a lot of promise in terms of all of these facets of the healthcare system. We need to pay very careful attention to regulation and what are the incentives of people in the system. If the incentives don't align well with the deployment of these tools, That's when we bring in policy, the government, whoever, corporate consortiums, in order to raise the floor. And then that might have to lead to shifting of things, like shifting of rationing to different buckets, et cetera, changes to the deployment of healthcare. But these are things that broadly seem, I think, quite productive and positive for the healthcare system. So let me wrap up, and I'm really looking forward to your questions. How do we pick people? Okay.
Hello, great talk, very fascinating. Thank you so much. Thank you, Dr. Ho. I was curious, I just did a quick search because these frictions seem very lucrative. You know, the asymmetry information seems very, very, very profitable to keep this going. And I just looked at the quick number about the 129.3 million spent by health insurance on lobbying, which seems to be a drop in the bucket compared to their profits. But how would do you have any ideas about how to combat this lobbying incentive that they're getting to not to have this inertia, not do anything about this, or what free market issues could help kind of come in that space to kind of turn it around?
That's a really good question. Oh, sorry, let me go back to the microphone. That's a really good question. I wish I had a great answer, in the sense that, you know, when I give this talk, it's really about what I think policymakers should strive for. Of course, strive for in a world where there's not a lot of bias induced by lobbying and things like that. So I think there's many areas, you know, it doesn't have to be just healthcare, where lobbying is an issue. And I don't have any particular solution to that. I think that if I was going to be more positive about it, I would say, well, as a policymaker, if you care about these issues, you can just message these issues, because consumers care a lot about the healthcare they receive. It's a very hot issue. And if you can find ways to illustrate that more seamless integration of tools is being hindered or slowed, that could be a very popular political issue with consumers, regardless of lobbying. The other thing which I have in mind, and I just don't have any evidence on this, is as the gap between what is happening. So let's take the provider website. The website of insurers where we're searching for providers. We should already have better versions of that, right? That's clear to me. But as society evolves with AI tools and deployment of tools in all sorts of products, the frontier of what's happening in other products is going to be way further away from what's happening currently right now on websites in terms of searching for doctors. So I think at some point that gap of what's possible versus what's being done is going to be so big that there's just going to be immense pressure on insurers and companies to raise that floor anyway on their own. But of course, what probably they'll try to do is raise it as much as they need to in terms of like how they could still attract consumers in the market. So it's not really directly answering your lobbying question, which I don't have a good answer for, apart from the answers everyone has in mind. But I do think that these are issues that will be popular with consumers.
Thank you I'm so excited people are out there doing this kind of work. I really appreciate it. One was kind of pushing back on a couple different questions I appreciated that you said it's not always the insurance companies that are the bad guys. My experience as somebody who has to price shop for a lot of things, and I live in this area, the hospitals are not always the good guys. And they have a very, very strong lobby in Washington, D.C., which is why we don't have site-neutral payment reform, which I think the previous speaker asked, and I'd really like to see. Price transparency, as kind of a market person, I thought, oh, this will be great. We'll have transparent prices, and I use it all the time. I heard a Yale economist say on a Zoom I was on that providers and hospitals have kind of gamed that in terms of they just put a really high price. Okay, you're going to make us put something transparent. I'm going to put something super high, but that's not actually what you're going to pay. I guess I'm kind of looking for answers on that. Do you think price transparency, what would make it work? For instance, I went for a colonoscopy and my transparent price was $7,100. And for a colonoscopy, but that was what they posted. So I guess, how do you see price transparency working better, or is it not? And can AI kind of help incentivize consumers to do more of their own price shopping?
Yeah, this is a group with a lot of expertise in price transparency. I don't know if I'm the highest on that, but I think it's a fascinating area. And so there have been rules on this, of course, as you know. I'm sure, like I forget the names of the rules, but there's a 2022 and 2023 government rule on price transparency. Now, you brought up one issue, which is kind of central just to start with, which is, are we reporting list prices, or are we reporting what's called allowed charges, which is what's actually paid by the consumer plus the insurer together, right? If you're reporting list prices, which is just whatever we decide to post, conceptually what an uninsured person would pay, even though it doesn't actually happen usually. If you're posting list prices, it's not helping anyone do anything, like any consumers at least, right? Maybe it's helping organizations collude with one another on their list prices, but apart from that, it's not helping with anything. If you post what's called allowed prices, then there's a question of, okay, the prices are heterogeneous across insurers, right? So United has a different price with this hospital than Aetna, which is a different price than Cigna. These are proprietary things, generally, these prices. And so then, the question is, are these prices being posted in a way that's really helping the consumer make a choice? Now, my understanding is that if you look at the contracts between hospitals and insurers, in some cases, provider organizations have clauses that actually don't let the insurer kind of post prices in a price shopping tool or something like that, right? And so there's contracting in the background that's happening. It's very, very complicated. Now, when we but let's imagine we have a world, which I think is possible, where you have the kind of actual price that your insurer, let's say United Healthcare, is charging at this hospital for this procedure, okay? Then you get into the consumer realm, and that's hard as well, because say you're going to a hospital for something that's expensive. Consumers have insurance, and if you're going to the hospital for something that's expensive, you're probably going to hit your out-of-pocket maximum in your insurance plan, if your insurance plan is medium to highly generous, okay? So then what happens? You see the price. You see, the price of my back surgery, is going to be $56,000. I'm going to pay $3,000 out of pocket. I go to this other hospital. The price is going to be $41,000. I'm going to pay $3,000, right? Which one am I going to go to? I might rather go to the one that's $56,000, right? That might be implicit signal of quality to me. And so price transparency and its promise, insurers are already very carefully trying to bring down prices and negotiate prices. So I think the promise of price transparency, that as we think about it, it rests with consumers. And if consumers don't have enough skin in the game, so to speak, there's no promise. But we don't want to give consumers a lot of skin in the game necessarily, because then they have lower insurance, essentially. They're less insured. And so that's why I think there's promise from doing price transparency. There's promise from, as much as possible, allowing consumers to know what they're going to pay. But in terms of the total impacts of cost in the healthcare system and as a panacea for the care you're going to receive, efficient care, I think it's kind of small potatoes, honestly, like relative to other stuff.
Hi, Doctor. Thank you so much for the presentation. So I really resonate with what you said about insurers do not have the motivation to create this very seamless patient purchasing experience. So just based on your observation and experience, do you foresee or have you already seen that maybe a private sector company will create something similar to like Landing Tree, more about for profit, but at the same time can really leverage the top-notch AI tools?
Yeah, I think you're getting to exactly the core of what I'm talking about, which is how will the potential of AI be leveraged? As someone who lives in San Francisco, you can't kind of throw a ball without hitting someone who's working on a healthcare startup, okay, in AI. And so there's lots of companies like this. But it's pretty well known in the kind of startup world that having an idea and even having the potential to kind of code or produce the algorithms for this idea, that's the easy part in healthcare. The hard part is getting a hospital to use it, getting an insurer to use it. And a hard part of that is getting through the whole kind of bureaucratic soup of data regulation and data access and real-time data integration and the incentive issues that I talked about. So I like, in some sense, like your question, like it doesn't change anything of the gist of what I was saying. I do think these things will be adopted and used. And I think that the amount they're adopted and used and the pace at which they're adopted and used is going to depend on the incentives.
Hi, thank you for a great talk. I have a semi-technical question and a comment. I think the emergency residency is 3 years in most places. I don't know in UCSF. I wonder if there's a difference between first, second, third year residents. I also, even the growth in 1 year can be tremendous. And then finally, although it's costly and unfortunate to admit patients that may not really need it, they're probably protecting the patient. It's not, sort of just careless work, because then the patient is obviously thoroughly evaluated.
Yeah, great. Let me start with the second part about protecting the patient. I agree. I think that if you're tired and you're fatigued, you would rather admit the patient and make sure they're okay and get more care than not. So I totally agree with that. And in some sense, the purpose of the study is not to say that what they're doing in that case is bad or good. It's just to say, this is what's happening. And so Dr. Chernew is doing something pretty different at 2 a.m. on Friday after he's been working for 24 hours versus when he gets to work and there's no patients yet and you're his first patient. And that's where the promise of kind of AI type tools lies. It can help standardize what he's doing in his practice. For your first question about the residents, yes, we actually are looking at that right now. And actually about 50% of the providers in those charts I was showing you are residents. Not a surprise to you, I'm sure, but most of the kind of primary physicians on cases in the emergency departments are third and fourth year residents. And so those are the people who we have the biggest sample size for, actually. And it's tricky because the first and second year residents, they're not actually primary physicians on that many cases. So even though they are on some, and we have that information, our study is really focused around who's the primary physician on this case. It's not focused on team production, which is an important part of the emergency department. So in future work, we're hoping to kind of expand our study into the kind of realm of team production. But I do think that thinking about this kind of learning you're talking about is like exactly what we have in mind, in the sense that, for example, you could train an AI model, which my co-authors are doing, on all of this very granular data at UCSF, and then you could port that model and offer it to doctors at another hospital, right, in a rural area or a different area, and you could say, hey, do you want the AI tool for UCSF emergency physicians? Now, there's a lot of issues with that I'm not going to go into right now related to kind of what are physicians' comparative advantages. But I think it's kind of a macrocosm in some sense of your first versus second versus third year resident, because you could also do that learning-wise and basically use it as a training tool for those residents.
So thank you very much. I appreciate the discussion on AI. I think everybody that I talk to, especially all of my husband's finance bro friends are all like, oh, well, how is AI going to actually work in healthcare? And lots of suggestions around that. Where I keep going in my mind, and I'm going to say this, and then I want to see if this policy problem is being discussed in your world, is it kind of reminds me of the promise of electronic health records and the discussions we had around that in the 2000s, and how just having an EHR was going to solve so many issues, and why were we not adopting it, and why was it not becoming, kind of the standard, and how we could share healthcare issues and that kind of stuff. But because of constraints at the national policy level and misaligned incentives, it wasn't being taken up. So then we sort of forced it through policy at the federal level, which is one of the major reasons why we currently have provider burnout. Because of poorly designed electronic health records that we were required to adopt, and they were only being able to be funded by the large healthcare organizations and by insurance plans, right? So I'm curious, as we discuss the incorporation of AI into healthcare, how are we going to learn from our mistakes in EHR implementation at the national level and the problems we're still adopting from it because of who owns the EHR really? And how we're going to overcome or avoid that in our future with AI.
Yeah, I thought about like 7 different relevant things while you were talking. So let me see if I can summarize some of them. I think at like a high level, some of the issues that you're talking about, there will be analogies and could still be there. And at another level, I think not. So let's talk about that. I think first, you talked about large organizations adopting and then like frictions to adopting and things like that. I think that one of the frictions in adopting tools is really getting kind of the scale and administrative data in the right shape, okay? Data in AI world, not just in healthcare, access to data is like the central asset in some sense, right? And so I think that to the extent that larger firms have more access to larger proprietary data access that they can use to train these models better and then leverage these models, I think that yes, there will still be kind of these kind of economies of scale effects like you saw with EHR deployment that pushes towards kind of larger firms having bigger advantages in the AI world. And you see more than ever firms trying to protect those data assets. And so I think, for example, there is an analogy with EHR. I think greater access to data and greater requirements of data provision in the healthcare world from companies into a central usable form, to me, it's crucial, and it's not the same, but it's kind of the equivalent of interoperability in EHR and interoperability requirements and deployment requirements. So that's some of the similarity. I think on the flip side, EHR is really about coding information, and it's really about generating the data in some sense. And so in that sense, there's a lot of work for physicians to generate that data. AI, at least the tools I'm exposed to and what I see, a lot of the thrust or the gist is really the opposite. A lot of the gist is really, let's make this process more seamless. Let's take decision-making or thinking or hassle out of the hands of physicians and let's let them do their job, right? And so, there's probably things I'm not thinking about right now, but my sense is that actually we're not in the same world where it's going to lead to kind of greater burnout. I think, in fact, the goal and the actual, what I see in many of the tools, which maybe is more important, is the exact opposite, right? Now, I think you'll have a separate set of questions that enter into that space, which are really important and also going to enter the consumer world and health and in other areas, which is people are going to start entrusting their decisions to the algorithms, right? For sure, this is going to happen. I mean, I already do it a lot of times, right? And it's easier. And so then I think what medical organizations have to be wary of, and which I have a colleague at Berkeley who studies this in a lot of detail, is do these algorithms have biases? Do these algorithms, are they really doing like exactly what we want? I think for medical organizations, they're going to be thinking, are we going to get sued if our algorithm has some bias? And we don't understand what's going into this algorithm because nobody understands. And so I think there's a different set of issues, but I think that apart from the fixed cost of data, I think a lot of the tools will make things a lot easier for doctors. And then I think the question is it too easy?
Okay, thanks very much.
Thank you.
We're going to take a break now, and we'll convene back for the third speaker at 11 o'clock. I'm trying to stay on time, so if you could wrap up your conversations, we're ready to start with the next speaker. We have one more speaker before lunch. We'll take a break then to allow you to gather your lunch and listen to the fourth speaker. So, if I could have your attention, please. I'm delighted to introduce our third speaker of today, Dr. Rina Conti. She's the Associate Professor of Markets, Public Policy, and Law. She's also the co-director of the Technology Policy and Research Institute in Life Sciences, co-lead Mehrotra Institute for Business Markets and Society at Boston University, Questrom School of Business. The really terrific thing about Dr. Conti, she her first position, when I first met her, she was in the School of Medicine at University of Chicago, and then she was recruited to Boston University, and she's in the business school now, so she has this terrific background of both the clinical expertise she picked up in Chicago and now is applying it to the business world and that side. So with that, I will get out of the way.
Thank you so much. Good morning, all. So first, I want to thank Professor Ho, who I have admired her and her work for all of my career. Secondly, I want to thank the Baker Institute for having me. I told Vivian that when I was a young high school student growing up in New York City, Rice was the place that I wanted to go for college that I couldn't go. So I'm so delighted to be here, and I so admire the Institute. I also want to thank my colleagues who have been presenting. I have learned so much already, and much of what I'm going to talk about is going to amplify the things that we've already been talking about by my fellow speakers. So, unlike the speakers that you've heard for the past two presentations, I'm going to stare directly at the sun. And specifically, I'm going to tell you about the important role of medicine in producing health and also our wealth and increasingly our security. I'm going to situate the Trump administration's policies in a broader context, and then I'm actually going to highlight some of the current administration's policies and talk through what their intended effects might be and also what their potential unintended effects might be. And then finally, I'm going to tell you about some policy directions I very much hope will garner some renewed attention, both in this current administration, but also at the state policy level. So we live in the biocentury, and there are remarkable products that have come to market and are promised to come to market that will transform our individual health, our population health, and our wealth over time, both from an individual family perspective, but also for society's perspective. If
If you are alive right now, you know about the incredible promise of the new obesity and diabetes drugs that appear to have transformed risk for cardiovascular events, progression for diabetes, and also might even act as preventives that, that support people's not progressing to more serious and costly care. But these new drugs are actually standing on fundamental alterations in how we think about the etiology of disease and how we might target disease in cancer, and in some other, in immunology and some other conditions as well. And when I first started working on this topic, I was really taken by the fundamental changes that we've made to the treatment of mental illness and substance abuse. And I've spent approximately 20 years thinking about the fundamental changes that we have made to thinking about etiology and disease progression in cancer. There are now cancers that were dread diseases and now are chronic. And in fact, there are even kids who have had diagnoses of leukemia and other really horrific childhood diseases that have now been the beneficiaries of gene and stem cell therapy and are living long lives. And then finally, we have had some transformative medicines come to market that have transformed infectious disease care from being something that, again, can set people up for a lifetime of very costly health interventions to essentially being cured by taking one pill a day for 12 weeks. Amazing, truly amazing. We spend approximately $1 trillion on prescription drugs a year now. That's approximately $1 in every $5 that we spend in healthcare in the United States. You might think to yourself, is that a big number or not? And much of the research that I have done has been thinking about, okay, are we spending too much on medicines or not enough on medicines? And the answer I have come up with is that it's both at the same time. And in fact, there's fundamental misallocation of who could get access to transformative medicines. And at the same time, there are lots of folks who are using medicines for which the evidence to support that use is simply not there. I also think that AI tools or better data might help solve some of these issues in the future. But given the data that we have now, understanding the difference between underuse and overuse might actually entail reading physicians' minds or handwriting, both bad. And it's not obvious that there's a lot of juice to squeeze in terms of thinking about better allocating a given dollar on healthcare by thinking through overuse and underuse, with some exception, which I'm going to talk about shortly. Instead, what I truly think is driving some of the misallocation, that is something that actually policymakers and others can really address through changing incentives, are the prices. So we pay the highest prices for branded drugs in the world, and those prices are, for the launch of new drugs, are somewhere on the order of $200,000 per course of treatment for a given year. Now, I stand at a university, we are all here, that is 2 years or more of a private education at a university. That is a mortgage, or really even the cost of buying a home. That is a lot of money. Why are these prices so high? Well, it's complicated. And I would answer that there's kind of 3 intertwined reasons why. The first is we pay high prices because we want to pull innovation into existence. Bringing these products to market is very long, it is very risky, and it's very expensive. And consequently, the only entities that are going to actually undergo that expense is if we essentially say, if and when you bring a product to market that meets our evidentiary standard for safety, quality, and effectiveness, we're going to guarantee that you have monopoly pricing power. In addition, the vast majority of drugs sold in the United States that are brands are insured. Because of the existence of insurance, every single dollar that I spend or you spend at the pharmacy counter is subsidized by the public in one form or another. That will naturally act to raise the prices that these pharmaceutical companies can charge for their products, holding all else constant. Lastly, we have misaligned incentives in our healthcare system. And specifically, many people don't know this, doctors, hospitals, and other parts of our healthcare system actually make more money when they use a higher priced product. So while our system wants to try to get folks to use the cheapest products out there, the ones that have lost their patent protection, there are incentives out there that actually benefit or drive people to use higher priced products, and drug companies know that and they price accordingly. Spending associated with very high-priced products needs to be managed. And the way in which medicine spending is being managed currently are in 2 specific ways. First, you might notice that if you have a prescription and or are dependent on medicines that are particularly high-priced, you might find that you are being asked to spend more and more money at the pharmacy counter at the point of sale. So what that means in practice is that insurance, although we have kind of universal health insurance for drugs, every single health insurer is providing some sort of pharmacy benefit, Americans across the board are being asked to pay more and more out of pocket to gain access to high-priced medicines. In addition, increasingly, insurers are walking away or are providing a lot of barriers to patients being able to access medicines that they have been prescribed. And in fact, 1/3 of all medicines that are prescribed by physicians are actually abandoned at the pharmacy counter. So that means that some physician thought it was a good idea for a patient to get a treatment to either prevent a condition or to treat a condition, and yet because of either insurance barriers or high costs at the pharmacy counter, people are actually not getting access. 1 in 5 Americans can't afford their medicines. And I know a gentleman in the back mentioned diabetes. Diabetes is the poster child for misallocation in our system. 1 in 4 Americans with diabetes can't afford or are rationing their insulin. This is not an indication that our healthcare system is actually working effectively. In addition, folks with very serious diseases such as cancer are also having trouble managing paying for their cancer treatments relative to paying groceries, food, rent, etc. This is a real issue. And you might think to yourself, well, we like to have people have skin in the game, have a little bit of costs that they have to pay out of pocket in order to make them really, really think through whether they need this product or not. But in the cases of insulin-dependent diabetes or cancer, there's no responsivity to price. These folks just simply need to get treated. And consequently, this is just misallocation of resources and it's misaligned incentives. There is a myth out there that we have a free market for prescription drugs in the United States. We don't. In fact, the medicine market is one of the most heavily regulated consumer products out there. We do so to advance several different objectives. One is to ensure that when products come to market, people who might benefit from them get access at an affordable price. We also have gold standard high quality medicines. So medicines are a very interesting consumer product. We don't know when we go to the pharmacy counter whether the medicine that is being handed to us is what it says it is on the bottle. We also don't know whether it is manufactured in high quality facilities or not, or that it is going to produce the desired effect that to improve our health. What we do have is a label and the full force of both the company's attestation that this thing is what it says it is and is going to, at least in expectation, produce health, and the assurance of the federal government that it is what it says it is. We have gold standard safety in the United States, and it is a fundamental role of the federal government to assure us that these things are what they say they are. We pay higher prices because of that, but I think we would all consider that to be a good thing. And then finally, we drive innovation for new products. Why? To improve our health, improve population health, and to improve our wealth. Policy, in a bipartisan manner, has expanded medicine access, innovation, and has increasingly improved affordability over the past 30 years. Under the Bush administration, we passed one of the most comprehensively sweeping increases in senior access to medicines. The reason that I say almost all Americans now have access to insured health care related to medicines is because of President Bush's activity in this setting. The Affordable Care Act built on that chassis. Additional protections to allow for Americans to have expanded access to certain medicines that were considered to be fundamental, essential medicines to improve health. It also served to alter the trajectory of spending by putting in a variety of different types of spending breaks on medicines. And then finally, President Biden passed the Inflation Reduction Act, which has multiple components to it, but has fundamentally expanded insurance coverage for seniors and has also put brakes on spending. I'm going to tell you about those policies now. So the Inflation Reduction Act has 3 key provisions. Inflation rebates, that's a brake on spending. Price negotiation, another break on spending, and benefit redesign for the Medicare Part D benefit, which is what seniors insurance benefit for drugs that are insured or that you get over the pharmacy counter. Inflation rebate caps are a policy that economists love, like me. Essentially, you should think of them as if we have been experiencing over the past 15 years, year-over-year price increases on existing drugs that are simply companies pursuing profit, not necessarily targeted to those products being new and improved or providing additional evidence of their effectiveness. That essentially what an inflation rebate cap does is it says, companies, we're going to allow you to raise the prices no more than the rate of consumer inflation, more generally. And anytime you pursue a price increase above the rate of inflation, we're going to tax you on that. Those taxes are going to go back into the trust fund to support Americans' access to health care. This is acting as a gap, as a very significant break on spending, and it's a break on spending for seniors, but it's also a break on spending for the commercially insured as well. I should have backed up and said the Inflation Reduction Act is anticipated to save about $500 billion over 10 years. That is real money. And that is real money that we can use to expand insurance access to products that really do change our lives, and also help save money for other important government goals. One of the important government goals was to lower the out-of-pocket costs that seniors face at the pharmacy counter for needed drugs. So the Part D benefit redesign was a bipartisan policy objective. You can think pre-IRA, seniors had to spend approximately $10,000 a year out of pocket until they flipped over to the catastrophic cap, where Medicare would pay 80% of total spending. For most of the fancy drugs that you see advertised on TV, by definition, if a senior is using those products, they're over the cap. So just think all the specialty drugs that you see, if people are taking them to take care of themselves, they're over the cap. So basically, seniors are paying $10,000 to get access to that treatment, and then ultimately the government was paying the rest. And you might think, wow, that's kind of weird. And wouldn't that potentially increase spending for seniors? Because basically people are speeding through that benefit as fast as possible, and the government is essentially handing the drug company a blank check for using that product afterwards. Yes, you would be right. Post-IRA, what we've essentially done is shifted the burden. We've lowered the out-of-pocket costs that patients have to pay for those high-cost specialty drugs to no more than $6,000 out-of-pocket costs. And then instead of handing a blank check to pharma to say, do whatever you want, instead, the government is sharing the responsibility for spending over that catastrophic cap with the health plans. So now the health plans have to do a much more active job of actually managing spending and finding ways that patients can both get access to needed care, but also not break the bank. And finally, and perhaps more controversially for some, Medicare price negotiation is a fundamental shift in policy, which for the first time in Medicare's history is acting to where the government is literally negotiating with drug companies for the prices of products. The drugs that are eligible for this type of negotiation are drugs that are very high spend, more than $1 billion, even more than that a year coming out of Medicare. And they're products that are long-lived. What I mean by that is they've been available in the US market for 9 or 13 years. And in fact, the majority of the drugs that have already been negotiated and are about to become available at much lower prices in January of 2026 are products that have been on the market for more than 13 years. Why long-lived brands? Why aren't we negotiating the launch prices of existing products or new products? Simply to make sure that we are not retarding incentives to bring new products to market. So when I was getting ready for this talk, I started thinking about, okay, what words would I use to describe the current administration's medicine policies? I asked my colleagues and my family members, and then I finally relented and asked AI. So I'm going to give you a moment to think about how you would describe these policies that you're seeing in the newspaper, and then I'll give you my word cloud. Here's what large language model came up with. For the remainder of my talk, I'm going to talk about the words on the left, and I'm going to talk a little bit about NIH, and I'm not going to talk about vaccines at all. But I'm more than happy to talk about it in the Q&A. So I believe that the Trump administration's key medicine policies are largely bolted on or building on what has already been done in a bipartisan way for the past 20 years. And I think they have, but with like slightly different emphasis. And there are really 5 key policies that are interrelated that I'm going to try to break down for you and then tell you. I'm first going to tell you what they are, and then I'm going to move on to telling you what I think the intended effects are. They are IRA and Medicare negotiation, tariffs, and the pharmaceutical industry, most favored nation, I'll define that for you in a second, the FDA Commissioner's National Priority Voucher Pilot Program, and direct-to-consumer sales. So an IRA and Medicare negotiation, there's no change. So inflation penalties are inflation penaltying their way. We're still getting very significant savings from that. And Part D redesign is now completed, so if you're a senior, you're already benefiting from lower out-of-pocket costs associated from these medicines. Negotiation savings is imminent. So literally the first set of drugs that have been negotiated are about to be available at prices that are somewhere between 60 and 80% off what we were paying before, starting in January of 2026. That will materially alter what seniors who take these drugs are at the pharmacy counter, but also in terms of their out-of-pocket costs, but also will fundamentally alter the trajectory of spending in Medicare. We've already completed round 2. Those drugs are also been announced and will take effect the following year. The round 3 is about to be announced, what products will be in that category, but we believe some of the early obesity drugs will be in that list. And the first round of Medicare negotiation drugs will affect the spending and the prices that seniors pay of approximately 10 million seniors. This is a massive change, and one that will truly, truly benefit many, many people. In the second round, there are approximately 8 million seniors that will benefit from these changes. One little wrinkle under the current administration policy is that this summer, Congress passed exemptions to what drugs could be eligible for negotiation in the future. And some of the most expensive, most high-spend drugs that the program pays for right now, think Keytruda, Opdivo. These are products that are expected to either be delayed in when they will be negotiated or may not actually get negotiated at all. This change is expected to erase approximately $80 billion in expected savings from the IRA. Tariffs. So in order to understand what's going on with tariffs, we need to go back before the tariffs were announced, and fix in our minds that although we think of the U.S. as being a very innovative place to bring new products to market, and it is, the U.S. is actually highly dependent on a foreign supply chain to actually bring these products to market. Specifically, India and China are responsible for the vast majority of generic manufacturing and also base ingredients. So my estimates are that there's approximately 70 to 80% of generics are coming from these two markets. And then, although there are a lot of drugs that are made in the United States, there are also a lot of highly innovative products that come from European countries, Switzerland, the UK, Norway, Italy, and Japan, especially for brand products. Because of very long-standing trade agreements, there have been essentially no tariffs on generics and very limited tariffs on base ingredients, and no tariffs on approximately 90% of global brand pharmaceuticals that are coming from overseas. There are some tariffs on some pharmaceutical products that are branded products, but they're on the order of somewhere between 2 and 7%, not zero, and certainly not the large numbers that we've seen announced in the more recent time period. So here's what's changed under Trump tariff policies. It's a little bit of an evolving situation. In April, the Trump administration announced 10% across the board tariffs on all imports with a grace period to negotiate individual trade deals. EU and US and Japan and the US and Norway have all agreed to trade agreements that encompass branded pharmaceuticals with an increase from 0 to 10 to 15%. The China situation is very different. The administration started with a 10% across the board cut, or across the board tariff, and then for a variety of reasons quickly escalated those tariffs on base ingredients up to 245%. Those are what the tariffs are right now. They are operative. There's a court case that is actually under appeal. Right now, we expect that we'll hear more next month about this, but you should think that right now China is facing 240% tariffs in bringing these products to market. On Liberation Day in August, Switzerland was imposed a 39% tariff on their products. So think Roche, Novartis. These are big products that are that treat cancer and immunology products that now face very significant tariffs. India was slapped with a tariff of 25%, and that was later doubled to 50%. That's where we are now. And then fast forward to this month, there have been new 100% tariffs that have been announced. Many countries scrambled to make additional deals with the administration. The big one that we are waiting on understanding more about is the UK and Ireland. AstraZeneca, there are a handful of other, BMS, there are a handful of other very prominent pharmaceutical firms that are domiciled in the UK and or in Ireland, for which these tariffs and what they ultimately get to will be material to us. Other country agreements are still pending. The administration, once they announced this in October, on October 1st, then said, given that countries are now coming forward to make negotiated deals, they've now halted the imposition of tariffs. There was a hairy week or hairy weekend in which pharma companies were frantically trying to get drugs onto shipping containers and airlines to come to the United States before this 100% tariff took into effect. Part of the tariff strategy you should think of it as not just getting countries to the table to make a better deal, but also individual companies to make a better deal on the prices that Americans are paying for their products. In spring, the administration issued an executive order imposing most favored nation clauses on pharmaceutical companies, targeting brands. The intention of the announcement was to equalize prices between the US and other OECD countries. There was a long list of demands in that executive order, but the actual specifics of whether this is new products or existing products, whether this would be mandatory or voluntary, were kind of hazy. Over the summer, the administration sent out public letters to 17 international medicine companies, threatening companies to use literally everything at the federal government's disposal in order for the companies to offer to the White House within 60 days best international prices on all drugs to all people enrolled in the state Medicaid programs, best international prices for all newly launched drugs, the launch of direct-to-consumer drugs that could be offered at low prices to cash-paying patients, and companies must commit to new domestic manufacturing capacity and also repatriate all profits achieved from higher prices in foreign countries. This is a massive change, and it is very different than what we have seen past administrations do. But you should think of tariffs and most favored nation policies as actually working in lockstep to get companies to the table to make deals outside of congressional legislation and with the power of the bully pulpit of the administration to effectuate. There have been 3 public MFNs announced by the time that I made these slides a couple of days ago. We have been told that there will be 1 public deal announced per week. So I've been waiting for whether there's going to be yet another deal being announced this week. The announced terms are actually quite limited, but they're very different than the threat. So what they all have in common are a voluntary choice by the companies that have announced these deals, on which medicines they are going to offer most favored nation prices to the state Medicaid programs. These products are largely older drugs that are facing either brand or brand generic competition. And consequently, we believe that the net prices of these products, taking into account their discounts and rebates, are already pretty low, actually. So it's going to be super interesting to see how low they're able to go on the commitments. All of these companies have committed to some domestic manufacturing, but the details are a little bit, differ quite substantially by product-drug combination, and they're a little slim on the details. There's no mention of profit repatriation, and it's only Pfizer that has agreed to best price on newly launched drugs for now. If MFN and the tariffs are the stick, the FDA Commissioner's National Priority Voucher are the carrot. It is a voucher for fast-track review of new medicines. It expires after 2 years of issue. It's non-tradable, and it's a pilot. It exists for 1 year. It's expected to reduce average timelines from approximately a year of review to a quarter. There are 7 product company pairs that have been announced, and they generally conform to advancing strategic priorities by this administration in 3 buckets: increased domestic manufacturing, addressing public health crises, and equalizing drug prices between the US and overseas. Lastly, there's Trump RX. This is essentially opening a channel that will expand the availability of direct-to-consumer medicine availability for cash-paying patients. The medicines that are being offered through these channels are largely ones that are going to make a deal or have already made a deal through this MFN agreements. These are cash pay. And you should think of it, Trump RX, although it's a government website, it's essentially acting as Expedia. It's linking to affiliate pharmacies or affiliates of the pharmaceutical companies to allow patients to access these therapies. I believe that there are likely positive effects of these Trump policies in a variety of different ways. There's improved patient affordability for selected medicines and patients. The biggest beneficiaries here are still the seniors due to IRA policies. There's the promise of increased domestic economic benefit. The tariff revenues alone may be very significant. In addition, we should see some increased domestic manufacturing over time, but only time will tell how much we're going to see and where. The innovation voucher may pull some new products into existence as well. And certainly these policies you should interpret as being advancing affordability goals, but they are fundamentally pro-business. This new exemption for negotiation, the avoidance of tariffs, threats, and the voucher is worth billions of dollars for profits, and you can see that signal in stock prices that have gone much higher since these announcements. And in fact, if you've been paying attention, there's a lot of worry on the street that pharma was really not a preferred investment target relative to AI and other things, and now the trade literature is all breathless about how pharma investments are back. I have some worries. Negotiation may cause prices to increase among non-Medicare beneficiaries. Tariffs may cause prices to go up, but are not actually likely due to the inflation caps that already exist. What they may do is actually increased prices in other countries that might worsen access and potentially health. And here, the place that I'm really focused on right now is the UK deal. The UK tariff deal is directly related to what the pricing the National Health Service will actually commit to on products moving forward. Expanded direct-to-consumer prices are they're actually very limited to a handful of products that we know of right now. And for some products, a 50 to 80% off is still too damn high. Because what is going to be asked at the pharmacy counter for a given prescription is $2,000 a month or more. This could actually worsen access for some people. And the big concern I have right now is that will insurers, especially self-insured insurers, drop coverage or worsen access even further now that these cash pay prices are available? Will patient assistance programs stop where these programs are actually a substitute for those as opposed to a complement? And then finally, will direct-to-consumer out-of-pocket costs count towards the deductible? Tennessee and Texas has rules on the books that actually allow cash payment to count towards high deductibles, but the rest of the states do not. And then finally, voucher products are shovel-ready. Because it's a one-year pilot and because they're already awarding vouchers, this is not going to materially alter innovation directions without a much longer term commitment and fundamentally altering payment to make sure that when products come to market, people will actually get paid for them. I'm going to impose upon you that I have another worry, which is, so this is a picture of the teapot scandal. Anytime I hear voluntary deals with no details, my spidey senses as a girl growing up in Brooklyn, I think to myself, oh, here's an opportunity for graft. So I worry about that, and I think it's going to be really interesting to see what we learn over time. I'm going to impose upon you one more minute to say that I do think that there are some policy priorities that are consistent with the goals of this current administration and are also bipartisan policy objectives. I hope that this administration and others will resist efforts to further erode insurance coverage, especially for kids and more vulnerable populations that are medicine dependent right now to take care of themselves, go to school, stay working. I would like to see more renewed focus on reducing that misaligned pricing incentive where other entities in our system make money off prices being too damn high. I am super passionate about kids getting access to the incredible advances of cell and gene therapy and others for highly innovative therapies. And here's a place where the incentives are all wrong. And so I very much hope and believe that there will be some renewed focus on that. The NIH and so public funding for science and translational research and translational product development and FDA funding go hand in hand to both bring new products to market and lower the barriers to entry for innovative products. So restoring and expanding access to that funding and that expert personnel is absolutely critical for bringing new products to market that we will all benefit from. And then finally, I think we have a highly vulnerable supply chain, and one that I think COVID has taught us could be improved in a lot of different ways. Targeted incentives to reshore or even re-engineer existing medicines that are critical to our health and wealth and security is an absolute national imperative and one that I anticipate will have a lot of support moving forward. With that, thank you so much for your attention. I look forward to your questions.
Great talk. Thanks so much. I have a couple of questions, but I'll be quick so you can go into whatever depth you want. First, you kind of touched on it at the very end a little bit about the potential, I think, for shortages and disruptions to the supply chain. And I just wanted to see if you could say a little bit more about the impact or expected impact of the tariffs on that, because I know a lot of the ingredients we get are even for, generics that are less costly. And then secondly, I'm really curious about the impact on domestic manufacturing. So my understanding is that there are very significant environmental impacts and costs to manufacturing drugs. And to what extent are we really, equipped to ramp up quickly?
Mm-hmm. Yeah,
Thanks.
Great question. Thank you. I'm super passionate about this topic. So myself and my colleague Marta Wazinska at Brookings Institute created this framework where we think about drugs being critical, we think about drugs to the production of health, we think about drugs that have very high reach. They're drugs that many Americans take every single day and or very vulnerable patients are reliant on. And then we think about, okay, what are the vulnerabilities or potential shocks? I would say we have increased the number of shortages and threatened shortages over the past 20 years of essential medicines. And much of that is about thinning the number of companies that are actually making this product. So a great example of this is we use antibiotics every single day. One could argue we overuse antibiotics for some conditions, but the supply chain of antibiotics is completely Chinese dependent, 100%. This is an opportunity for the US to rethink either reshoring that capacity or re-engineering currently available antibiotics to be more environmentally friendly, maybe more cost efficient as well, and would make us less vulnerable to potential geopolitical risk. I do think that there are some products that we are vulnerable to shortages on, either because of geopolitical risk or because just there's not a lot of redundant supply, either of the base ingredient or of the fill and finish product, that have environmental concerns. But I would argue material examples are actually quite limited of those type of products. And here's where I think smart re-engineering incentives might actually solve some of these problems. Thank you for the question.
Thank you, Professor. I just wanted to ask you to consider something, and I mean it in the most best way, in the highest respect. Academia has done a very poor job of informing us. We really do not know what process is better or worse, and we've been riddled with sensationalism of leaving a child or somebody without a medicine, and nobody ever wants to do it. And then I do a lot of work in church, and then churches have to pick up the problem that you're unable to explain to us. So let me give you an example. While a lot of your information is very factual, you have missed one concept. The decrease of purchasing power that the middle class and many people have felt in the last 5 years, it's up to 50%. So we need to compare the loss of purchasing power at different levels with the consumption of what your budget is of medicine consumption. And that way we can will be able to see, for example, if I've lost 50% out of a $100,000 income in purchasing power, in goods and services, go to the supermarket, buy a spare part in something, but my medical service has only gone up in 10K, then the story is I'm 40K in the problem. So you're really not helping me. The second thing, and I mean it as I also am a professor, I'm retired, governmental accountant, and we have done a horrible job in instituting and expressing this is what Mr. Trump is suggesting, this is what Mr. Biden is suggesting, this is the new one. If you're making 10K, here's the problem. If you're making 20K, here's the problem. And being able to express it so that the consumer, the public at large, can make a decision. Right now, I don't even know who to listen to the news. I'm going to BBC because if you listen to one news, they paint one picture. If I listen to another picture, I've got to figure out if you're a Democrat or a Republican before I listen to your thing. So tell me something, Professor. How would you answer those two concepts? And how can you make us have a better country who's more caring?
Thank you so much for the frank comments and questions. I'll say it this way. I actually think that academic research has done an incredible job of showing us where we think we're misallocated. What I mean by that is prices are too high. Full stop. There are a lot of good economic reasons why those prices are high, but they're still too high. And especially for people who are medicine dependent, who have chronic diseases that they're trying to manage these products with these products. I do think that it has been a bipartisan policy to reduce out-of-pocket costs at the pharmacy counter. That is, after all, what really is driving the Medicare Part D redesign. That is fundamentally going to lower people's out-of-pocket costs for seniors. That doesn't go far enough. Why? Because there's a whole bunch of us who are commercially insured who are still paying too high prices, and in fact might even pay higher prices because of unintended consequences associated with policies. These direct-to-consumer products that we now we're kind of endlessly bombarded with on our phone, they are trying to address the problem in a different way by lowering the pocket costs for people who are paying cash pay. But is it realistic to think that a family of four who has an average income of somewhere around $60,000 can pay $2,000 for a needed prescription out of pocket? No, it's completely unrealistic. So I actually completely agree with you that what I would like to see, one of the things that I'm really working on and would like to see more of is thinking about pricing transparency, where we're being a lot more transparent about what it's actually costing real people to get access to the medicines that they need at the pharmacy counter, whether you're cash pay, you're commercially insured, or you're insured by a government insurer. So thank you.
So the elephant in the room that I'm not hearing mentioned is we just broke $38 trillion on the national debt. So my problem is you set it up where they're making these adjustments so that the customer going to the pharmacy is paying less, but now it's being supplemented more by the government. And I just think that has a huge negative that I think we have to consider.
So for the IRA, it does both. It addresses spending by mitigating it, and it also expands access to seniors at the same time. Is it enough? We spend $4 trillion-ish on healthcare right now in America. There's fundamental misallocation of those resources. Could we spend less and get just as much health? Yes. But doing so is both about getting the prices right, the incentives right to companies to bring these products to market at a more cost-effective price, and mitigating utilization that is overuse. The problem with staring at overuse, which is how I started my talk, is that it's really hard to discern overuse and incent our healthcare system to actually get the right patient to the right treatment at the right time. I'm all for it. It's just that it's very difficult to do.
Sure. Thank you for being here. In the context of the tariffs, I know there's some court cases coming about whether Congress has that power or the president. And the president's trying to do everything unilaterally right now. Congress is kind of moribund. We want them to do much. From a policy perspective, you've got your think tanks, your academia, you've got your agencies, and then you have Congress and some of those committees. Where can you tell me to look? Where is really good policy going on that has a realistic chance of becoming a policy given the politics right now? Can Congress do more? Can the Help Committee do more? The Finance Committee do more? What out there gives you hope about implementation in health policy?
Thank you so much for the question. What gives me hope is that the vast majority of people that I know that are working in this administration and are also working in current Congress, especially the committees that have jurisdiction over spending on Medicare and access to medicines, they understand the problem. They understand that we have a fundamental spending problem and we have a fundamental access problem at the same time. The question is, what are we going to do about it? And I actually think that some of the changes that are being pursued will actually make a dent in spending. The question is whether or not that will translate into actual material savings for real people sitting around the kitchen counter trying to figure out how they're going to afford their drugs and afford all the other things that they have to do. I don't know. But I'm hopeful that there are some very, very good people who are expert and who understand this very complicated system and are trying to chart a path. I also think I haven't gotten here yet, but I actually think that there's a lot of power in the state legislatures to really, really think about brakes on spending or increased affordability and access at the state level for folks who really do need medicine access now. And I mentioned already Tennessee and Texas have these policies, but there are a variety of other policies that are either trying to advance access to make sure people don't lose access to needed medicines, regardless of how fragile the insurance coverage market may become, or actually try to expand access to really needed therapy. So thank you. Thank you.
Thanks for that excellent talk, Rena. So I think you'll agree with me. We had three really fascinating presentations today, very thought-provoking. We still got one more that's coming after lunch, and thank you to the audience for asking some very challenging questions and thoughtful questions as well. So lunches are available outside. Right outside in the lobby. Feel free to go ahead and pick up your lunch and a drink and come back here and eat. And you're welcome to eat during the next presentation, which will start again at 12:25. Thank you. And so we are ready for our fourth and final speaker today, and I have saved the best for last. We've got Dr. Julie Zissimopoulos, who is a professor chair of the Department of Health Policy and Management at USC, and the co-director Aging and Cognition Program at the USC University of Southern California, I know some people use is also University of South Carolina country things, but this is University of Southern California, Schaeffer Center. And this topic, I think, having personally experienced the challenge of dementia in my family, and I know there are plenty of other people in this audience who have also struggled with this, you realize it's different from the other diseases because there's no magic surgery. Currently there's no super expensive miracle drug, but has just, it's like a train wreck heading towards the entire healthcare system. So I'm very delighted that we could get an expert to talk about this topic. Julie.
Well, good afternoon. Thank you for staying with us through the rest of the program. Thank you to Dr. Vivian Ho and the Baker Institute for having me here today, and to my fellow speakers who have provided us with excellent talks and have really set a wonderful foundation for me to build from in this talk. So as Dr. Ho mentioned, I'm going to be talking about the population burden of dementia. So my research has been focused on the economic impacts of longevity and population aging. And in 2012, they released the first national plan to address Alzheimer's disease. And that plan was really a call to the research and policy community to make an impact, find opportunities to address this burden. And that's really where my research ended up moving to the same area. And health policy and health economics has a lot to say in finding these opportunities to reduce the burden, because the burden is both health, social, and economic. So I do want to acknowledge research support by the National Institutes on Aging, and disclaimer, no conflicts of interest, and all of the opinions are my own. So I'm just going to start off with my message that I will start with and I will end with. So first, that the public health and financial burden of dementia is very high now and is growing, and I'm going to show you some numbers to support that statement. The advances in terms of prevention and treatment and dealing with the social consequences have been slow, but I'm actually very optimistic. They have accelerated quite dramatically in the last decade, and I think we have a lot of potential here. So I'm going to tell you a little bit about that. I think we are really right now at an important turning point. There are opportunities to change this trajectory that we're on, and policy has a really important role to play. Thinking about how we might address the burden by supporting innovation in this area, early detection, treatment, better care models, and importantly, supporting the very large caregiving workforce that is super important to the care for persons with dementia. Okay, so let me start off backing out a little bit. So dementia is a syndrome. So it is a description of a group of symptoms defined by cognitive and thinking impairments that impact activities of daily living. It is a progressive disease and it is very costly. So the most common type of dementia is Alzheimer's disease. It's not the only. The other most common are listed here: vascular, Lewy body, and frontotemporal. But what we've learned over the last couple of decades, primarily through innovations in our imaging technologies and in autopsy studies, is that most dementia is mixed. So you have the Alzheimer's disease pathologies, but you have other pathologies. And that's kind of a very important point because it explains a bit why it has been so challenging to find effective treatments in this area. The pathologies of dementia occur decades before the symptoms appear, and the decline of all these dementias is progressive. So starts off with mild symptoms that continue to progress until loss of independence. So on average, people with calling it dementia more generally live about 4 years, but there is vast heterogeneity in that, and there's really a long right tail. So about 10% live 8 or more years. So all of that description leads me to some sort of description of why this is costly before I get into the numbers. So to detect it, as you might have guessed now, is very challenging. If there's mixed pathologies, there's different pathologies, and the tests that we currently have to try to disentangle what etiology, what kind of dementia you have are very expensive. They're essentially PET scans or lumbar punctures. What we have seen in studies over and over again is that the medical care use tends to increase in spending before the person is diagnosed with dementia. That is partially in part of this very complex pathway to getting a correct diagnosis, but also because people who are diagnosed late have cognitive impairment, and that often has led to some overuse of, let's say, emergency department and hospitals. There's quite a large group of studies that have shown these undetected or late diagnoses are associated with high use of the emergency department and hospitalizations. And then on the other sides of costs, I mentioned that the disease is progressive. The thinking, the memory, the mobility issues decline over time. So do care needs. So care needs might start off with transportation, help paying bills, but quickly move to trouble eating, dressing, bathing until the loss of independence. And this is highly impactful for the caregivers that support them, most of which are family members. And I'll talk quite a bit more about that. But when a family member is caring for a person with dementia, this is different than other kinds of caregiving. The hours are longer, they're more intense, and so the impact on the caregiver's own health, their ability to maintain work in the workforce, their earnings, and quality of life decline. So let me tell you a little bit about the numbers. So today, there are 5.6 million Americans living with dementia, and they are supported by 6 million caregivers who provide 6.8 billion hours of unpaid care. That 6.8 billion hours is about 3 million full-time jobs. I'm defining caregivers here as people who are helping with activities of daily living. So it's really an underestimate. It's not counting all of those other types of help that caregivers are supporting. These numbers are going to increase dramatically. By 2050, we will have 10.3 million Americans living with dementia, and associated care hours will also increase if nothing changes to 15.6 billion hours of unpaid care. So it's no mystery what's driving these numbers. It's longevity. We really witnessed a longevity revolution in the 20th century. In 1950, there were 12.3 million people ages 65 and older. By 2025, there is 61.2 million people ages 65 and older, so 8% to 18% of our population. This is driving the number of persons with dementia. Dementia increases dramatically with age. So you can see by the graph, among persons who are 65, we'll have about 2 to 3% with dementia. You get up to age 85, you're up in 16% of 85-year-olds with dementia, and your lifetime risk after 85 increases dramatically. So now I want to give you some numbers about costs. Individuals and families bear most of the burden. We've been talking a lot about the healthcare system, and I am going to talk about the healthcare system, but I want to start here with the burden faced by the individuals with the disease and their families. So the total costs are in 2025, so this is 1 year annual costs, $781 billion. And why I say it's borne by individuals and their families is the largest amount of that is associated with the quality of life loss of persons living with dementia, followed pretty closely by the $233 billion is the value of the informal care. So that's all the hours of care that is provided unpaid by primarily family members, and we value it here, this number, at a replacement rate. So the hour is worth what you would go to the marketplace to hire a paid caregiver, But it's similarly high if we take a different approach to the value and we look at opportunity cost of time. What's their value of an hour? The other types of costs borne by the family are also monetized here. There's the foregone earnings of care partners. So about 50% of those unpaid caregivers are the children of the people with dementia. And so these individuals are, for the most part, middle-aged. A lot of them are at their peak of their earnings, right? They're 50 to 64 years old when they're providing care. So there's earnings loss, $8 billion, and then there's also quality of life loss associated with this intense amount of hours that you're providing as a caregiver. So I don't want to disregard medical and long-term care costs. Those are also very important, $232 billion. I'm going to talk a little bit about what those are and who bears them in this next slide. So this is just looking at that $231 billion of medical and long-term care costs. So most of those are borne by Medicare and Medicaid. That 71% are healthcare medical costs and long-term care costs. But not an insignificant amount of that is borne out of pocket by families, and that's really related to the long-term care costs. Because as I will talk a little bit more about later, only Medicaid covers the long-term care for individuals. Medicare does not cover that. So for people who are not Medicaid eligible, they're paying out of pocket if they're using direct care, workforce, nursing home, assisted living, any of those long-term care facilities. So where I started was we are at an inflection point. We have an opportunity now to really address this burden because of the progress that we've made over time. So Alzheimer's disease was first described by Dr. Alzheimer's in 1906. And there really was limited progress between that 1906 time period and 1970. Important, but limited. So important in that they identified the beta amyloid and tau proteins that are associated with Alzheimer's disease in particular. And one of the genes that is a gene that puts you at a high risk group for Alzheimer's, ApoE, was also identified at this time. But it really wasn't until over 100 years later that these advances have really taken off. And so some of the really key advances that are leading to this opportunity moment that we're at is in diagnostics. So we finally had in about 2012, 2014, an imaging agent, and that attaches itself to those amyloid beta proteins that can be detected by PET and is one of the key markers of Alzheimer's disease. Today, we now have blood-based biomarkers that are not widely used, but some have been FDA approved, that have the opportunity to identify persons with these proteins at potentially a lower cost. And we have our first disease-modifying therapies, lecanemab and donanemab. And I'm going to talk quite a bit about that in a few slides from now. But these are really, really key advances to thinking about opportunities to reduce the burden and the overall cost of this disease. So I want to talk a little bit about kind of going back to that first national plan. One of the key outcomes initially of that national plan was to direct resources to dementia. And you'll see in 2014, you have about $500 million, $500 or so million of funding for Alzheimer's disease, NIH funding for Alzheimer's disease, that has rapidly increased over time. In 2024 is about 3.8, and the Senate proposal request for Alzheimer's research is $3.9 billion. NIH funding has been very instrumental to these advances that I mentioned. Important particularly is in the funding of basic science. So that is an area where there are market failures. There are no patents for basic science, and patents are for innovations. And so NIH has funded many of these very important basic science that have led to the disease-modifying therapies of today, particularly around amyloid and tau. NIH has also funded the development of and validation of diagnostics, and diagnostics are super important for identifying the appropriate people for the clinical trials that will help us produce better drugs in the future, and for identifying the diseases. So it's not enough to say someone has dementia. We don't know how to target it if we don't know what pathologies that they have in their brain. And NIH has also funded really important work on the trial and regulatory infrastructure, and that has really reduced the cost for pharmaceutical companies to take on what has been a very risky endeavor given the decades and decades of failed clinical trials in this area. NIH funding has been very important to moving this research forward, and as most of you know, it is currently under threat. We can only hope that the Senate proposal request for the $3.9 billion is able to be achieved to move this research forward at this really critical juncture. So I want to talk a little bit about the therapies for Alzheimer's disease. So I mentioned it was first described in 1906. You'll see from this table that the first FDA-approved drug was in 1996. It's in light blue because these are symptomatic drugs. So they treat the symptoms. They're effective for some people for a short period of time, and basically they reduce the cognitive impairment for a period of time. And up until 2023, that's what there were. There were some symptomatic treatments with, I would say, kind of moderate efficacy. 2023 was the first disease-modifying therapy, lecanemab. The brand name is Leqembi, and then followed by FDA approval of donanemab or Kisunla. These are different drugs. I'm going to spend a little bit of time talking about them on the next slide, kind of what do I mean by disease-modifying. But there's one thing that is important to note at this stage, because I'll come back to it, is that these drugs are targeted for persons in early stage. They do not work if the disease is advanced. They're monoclonal antibodies. They attack amyloid. So they are only given to people with either mild cognitive impairment or mild Alzheimer's. And they're only targeted for persons with the pathologies of Alzheimer's, those amyloid plaques. So what is so different about disease-modifying therapies? Well, as their name implies, they modify the disease. So they slow the progression of the disease. And this is represented in the graph for lecanemab by that blue line. So a symptomatic treatment would show kind of a higher cognition, but then as soon as that wore off, you would drop down to the natural progression of disease. That, hopefully you can see the colors, that sort of purple and red, those underlying. So it changes the trajectory. It slows the decline of cognition. And you see it for both of the drugs. So these drugs are biologics. They're given by infusion every 2 weeks for lecanemab or once a month. They have what we can argue about. I would say kind of moderate efficacy. Some people say it's not very efficacious, of a slowing of 27% or 35%, but they do modify the progression of the disease. They also have potential serious side effects, brain bleeds, but most of these side effects are picked up early for those who have them through monitoring. What has gotten most attention with these disease-modifying therapies is their price tag. So the drugs themselves, you see $26,500, Medicare is covering $32,000 for donanemab, but there's many other costs that are involved. There's the initial PET scan to identify that you have the amyloid, that's the target of the therapies. There's the MRI that is for monitoring of the symptoms and ensuring that the drug is actually doing what it's supposed to do. And for those who have their traditional Medicare, they potentially could be facing quite a bit of out-of-pocket costs associated with use of these drugs, despite them being covered by Medicare. So the costs have gotten a lot of attention, and this, what some have described as kind of moderate efficacy. But what that doesn't really tell us is what is the value to the individual, was the value to society of these drugs. And by value, I want to take you back to how I described costs at the beginning, which is not just the costs associated with medical care, but all of those other indirect or intangible costs associated with quality of life and associated with the care that is needed and provided unpaid by family members, the caregivers. So we looked as a group to see what is the value of disease-modifying therapies that can moderately slow progression of the disease. And so the headline is, with treatment in 2050, there are 2 million fewer Americans with dementia. So what the experiment was if we can reduce the percentage, the risk of transitioning from mild cognitive impairment, where you still have independence, many are still working with mild cognitive impairment, if we can reduce the probability of transitioning from that stage to dementia by 30%, what would be the impact on prevalence of disease? And that's what this graph is showing. The top black line, the 10.3, is the number of persons, number of Americans with dementia in 2050 without any treatment. And the bottom line, the 8.17, is the number if you have a treatment that reduces risk of transitioning from MCI to dementia by 30%. So this is not an experiment of curing it or even providing a lot of efficacy. It's just a 30% risk reduction. And the point is that you can have a large impact on the total number of people with just delaying that onset or reducing the risk that someone gets progression of that disease. So what does that do for costs? So on the far left-hand side column here is the total costs. So that's the medical long-term care, quality of life loss, value of caregiving, if there is no treatment. So that's $1.6 trillion in 2050 if there are no treatments. And then the far right one is if we have that experiment that we reduce the risk of moving from MCI to dementia by 30%, total costs in 2050 then are $1.2 trillion. So still a lot, but it's a $320 billion in total savings with just treatment that's mimicking what we currently have. In the bottom box, that is looking at the long-term care costs and medical costs that are primarily paid by Medicare and Medicaid, 70% of that paid by Medicare or Medicaid. So that leads to a direct $71.4 billion cost savings to those programs in particular. So I started off again by saying there's a lot of innovation in this area, and this circle on the left, which you're not supposed to be able to read, shows the drug trial pipeline. This is a great study by Cummings and co-authors. They put this out every year to illustrate what is in the drug trial, what's in the pipeline for therapies for dementias going forward. And so it's broken up into different areas. So you have in the top green, those are the biologics. So that's your lecanemab, your donanemab. Your purple, the largest one, are the small molecule drug trials. So those are going to be, the pills that they're developing. Some of them may be repurposed drugs. Others are new small molecule drugs. And then the other ones are the symptomatic drugs. And then as you build out on the circle, you have the outer circle is drugs in phase 1, phase 2, and phase 3. So this is to show you that our drug trial pipeline is very robust. I'm going to give you some numbers up here: 182 clinical trials, 48 in phase 3. There was, as in most areas where there's big innovation in biologics, there are a lot of costs involved. So CMS estimated that when Leqembi was FDA approved, it would cost $3.5 billion to the program in 2025, this year, with about 130,000 individuals treated. Well, that actually has not played out. Only about 13,500, as of earlier this year, that's the latest report I could find, only about 13,500 individuals have been treated with Leqembi. So the costs in terms of the drug costs have not risen to what was expected, but that's not to say that they won't in the future. The pipeline, as I said, was robust. We expect that the future drugs will be more efficacious, fewer side effects, and likely be available in administration modes different than infusion. So part of the barrier to receiving the treatment for persons that are eligible is the infusion treatment every 2 weeks. You need to be near an infusion center. You need to be able to have constant MRI monitoring. So policy has a really important role to play here, particularly in terms of patents that protect drugs, bring value to the manufacturers, and really pushes forward this innovation. We had Dr. Conti telling us a little bit about Medicare price negotiations, and she made an important point, which is that these are for long-lasting drugs, but in terms of where drug companies invest, it also makes a difference on whether they think price negotiations is the future, and then they're making decisions about which kinds of drugs to move forward on. And the exemptions are different for small molecules and biologics. And really my point is to say that all dementias, Alzheimer's, mixed dementias, are very complex, multiple pathologies. There's inflammations, there's plaques, there's tangles, there's a lot of different complexities of pathologies involved. And so the future is combination therapy. So we need a drug pipeline that produces many different types of drugs so that we can understand what the best combination will be. And so we need to be careful about policies that have a really good intention, lowering the cost of drugs, but have these unintended consequences on innovation going forward. I also mentioned that in this drug pipeline, we had those small molecules that are usually pills versus the biologics that are infusions, and the cost of those drugs going forward will be different if they land on Part B or Part D, in large part because of the IRA, which allows negotiations differently, and then also in terms of what cost controls can be used. So for Part D, there's quite a few different cost controls that my fellow speakers talked about through formularies and prior auth, and that's very limited in Part B. And that's where the current drugs sit, right? They're infusions, so they are reimbursed in Part B. I should mention my last point, which is that the studies really are inconclusive about whether cost controls impact R&D or not, or if they really just discourage low-value products. So it's really kind of an unclear from the empirical studies where the long-term effects on innovation are. Okay, so the disease-modifying therapies that we have and the ones that are being developed for the future target early stage disease. So dementia must be detected early. And here again is where policy has an important role to play. So we have no national screening program for cognitive impairment, but we do have, since the ACA, the Medicare annual wellness visit. It's zero cost to the Medicare beneficiary, and it's really a preventive treatment. And you can see here what it covers. But the part that I want you to focus on, that it requires a cognitive assessment. So in theory, beneficiaries from the time they enroll in Medicare and have their initial Medicare visit. We can have a tracking, they can have a tracking, their physicians can track their cognition over time to detect where there might be an issue. Unfortunately, it's not perfect. There's been not 100% uptake of the annual wellness visit, even though it's zero cost benefit. And there's been, in one of our recent studies, we found that most patients report that they did not receive a cognitive assessment, or if they did, it wasn't with a standardized validated tool. It was of the nature, you having any concerns about your memory? Yes or no? Okay, we'll move on. So again, here policy does have a place. I mentioned 3 things that came out of a paper that a working group paper that was led by Soren Mackey. If you tie AWV reimbursement to using a standardized tool and provide guidance on that, then you can provide support for physicians using that tool. There's also a barrier in integrating these assessment tools into the workplace, but again, here policy has a role to play, supporting either the technical assistance or the grants to integrate these tools into the healthcare workflows. And then we know from studies across all kinds of services that the services that are reimbursed at a low rate are used less than those that are reimbursed at a high rate. Currently, AWV is considered a low rate of reimbursement for all of the kind of assessments and time that a physician needs to spend to do a thorough annual wellness visit. So we can think about increasing the reimbursement, which provides incentives for physicians to provide this. There are other types of financial incentives in our healthcare system that may help with this detection and diagnosis. And one number I forgot to tell you, which is somewhat key, is we think the rate, and I say we think because there's different estimates, but we think that it's about 40% of the population with cognitive impairment are either diagnosed late or never diagnosed. So that getting people detected and diagnosed is really important. Turning back to my point here, besides the annual wellness visit where we can detect cognitive impairment and its trends over time, there are financial incentives. The one that I'm pointing to here is the Medicare Advantage risk adjustment payment model. So Dr. Chernew told you about Medicare Advantage plans, and they're paid by risk adjustment, which ties the reimbursement to the health of the patient. Health is determined by other things, but primarily by diagnoses. So dementia was not part of that model. It had been a decade or more past, was not, and now it is again part of the risk adjustment model. And that was a change that reflected how expensive persons with dementia are to care for. But when they reintroduced dementia coding in the risk adjustment model, the change is about same as if someone had diabetes. They put 2 codes in with the same weights, so there's no severity code, and that was hoped so that the hope of that was that it would dampen upcoding. So diagnoses that were given to increase reimbursement that may be inappropriate. And so what the graph is showing you is the effect of this financial incentive on diagnoses. So before the risk adjustment change, persons who were in Medicare Advantage plans, all else equal, were diagnosed at lower rates than those in traditional Medicare. After this risk adjustment, there were more diagnoses. In some additional analyses, we found that those new diagnoses were at people of high risk, older ages, other characteristics that made them at high risk. But what we really don't know is to what extent this is better and earlier diagnosing, or whether it's inappropriate diagnosing, and or did it lead to better care, which is ultimately the goal of getting someone detected and diagnosed. So I've talked about therapies and detection and diagnosing. Well, that is all followed by cascading needs, care needs that are primarily met by their caregivers. So let me talk a little bit about the caregiving dimension of the costs of dementia. So about 65% of persons with dementia live in the community and 35% in nursing homes or assisted living. As I mentioned, Medicare does not pay for the long-term care. It's very expensive. I give a figure here that is on an average for a nursing home, about $120,000 a year. Medicaid does reimburse. There are other issues associated with that, low supply of nursing homes that will take Medicaid-eligible persons. So ultimately, most families are paying out of pocket for any type of paid care, whether it be nursing home, a direct care worker, or they provide it themselves. And as I have in the big box there, 80% of the care received by persons with dementia is unpaid by family, primarily spouses or adult children. So again, policy, we don't have a policy to support our caregivers. What I have in this table here is the federal policy that does exist. And what you'll notice is that the only policy that's targeted towards caregivers is that top line, that National Family Caregiver Support Program. It's small, it's about $145 million. It's to support caregivers with respite and some training. It's small and it hasn't grown over time. There is a Medicare hospice benefit that can provide some help for caregivers with respite care. And then there is a new Medicare Part B reimbursement for caregiver training. So family caregivers don't receive any training in how to appropriately care for their loved one with dementia. It's a new code. We don't yet know how much of an uptake it is we have seen, and how much spending is associated with it. So the largest program that supports our caregivers who are critical for the care of persons with dementia are these home and community-based services, and those are provided through Medicaid state waivers with federal matching. And there's a lot of heterogeneity across states, but generally these waivers help pay for the direct care workers, respite care, and some of the states, they actually pay the family caregivers, so the unpaid caregivers become paid caregivers. And they have, in a very recent study, we've shown that those make a difference. So people who live in states where they pay the family caregivers reduce their use of paid care and supply the care themselves. So what happens with Medicaid funding reductions? So this is an important policy discussion right now. The amount of Medicaid funding reductions that have been proposed are very large. Home and community-based services are optional. States provide them optionally and rely on the federal matching. So when you reduce Medicaid, they're likely to be one of the first services that go. Whether it'll end up saving the federal government any money is unclear. Medicaid, if you stop supporting the caregivers, then care often shifts, this is what we've seen in literature, to more costly institutional care. Less caregiver time often means other healthcare service use goes up, like emergency department visits and hospitals. And if workers, family members, are now providing the care that they used to be able to provide by paying for a paid worker, then they have issues with staying in the labor force, productivity, and their earnings and quality of life. The other policy that has been proposed is a caregiver tax credit at the max of about $5,000 a year. And given all the numbers that I've showed you, $5,000 is really just kind of a very small amount relative to the size of the dollar that is value for their time. So on the other side of the family caregiver are the direct care workforce. Families rely heavily on this also. So even though they are providing care, often families have to pay for the direct care workforce, or as the disease progresses, there's a need for nursing home, assisted living, other types of care needs. 28% of direct care workforce workers are immigrants. What we have is a standard supply-demand problem. So we have growing demand for this paid care workforce, and we have shrinking supply. We have shrinking supply before the immigration policies that I'm about to talk to in a minute. There's this workforce already faces many challenges. It's a low-wage workforce. There's high turnovers, but immigration policy is really exacerbating the problems in this workforce. And there's two policies that I mentioned in particular: the temporary protection status. So this is being terminated or targeted to be terminated for selected countries, and many of those countries that are selected are large providers of direct care workers in the U.S. And then generally, immigration policies that are targeting undocumented workers do have these spillover effects to documented workers and families. And again, this workforce relies heavily on the immigrant population for providing that really, really important care that persons with dementia need. So I'm going to end where I started, which is, I hope I've convinced you that this is a very large and important, both public health and finance crisis of dementia, and it is growing quickly with our aging population. We are at a turning point. We have now seen really, really important advances, and policy is at the point where it can support the continued advances in all areas: detection, treatment, care, which I didn't speak a lot about because I just don't have enough time, but I can answer questions. So I guess I'm just end on that. That policy has an important role to play. We have a moment in time here that is key, and I hope that we can all rise to the challenge. Thank you. I look forward to your questions.
Thank you. That was really great. And I'm as a child caregiver of a mother with Alzheimer's, I do thank you for all the work that you're doing. So, but that raises one of the kind of policy implications that I didn't hear you touch on, but that I think has an effect on perhaps early diagnosis. So prior to actually being diagnosed with mild cognitive impairment, it's up to the patient to be willing to take those tests and admit that they might be having some cognitive impairment. And so one of the reasons that I think potentially that people are delayed in diagnosis is their unwillingness to actually participate, despite maybe the family's recognition that things are changing in their loved one. And then we have policies like HIPAA that prevent caregivers that are watching their family decline from actually speaking with or intervening in that care. So as we move towards having drugs or potential therapies, is there any space in the policy making that is looking at the ethics of the caregivers who are going to be impacted by this diagnosis, being allowed to be involved in the potential diagnostic process? Because as long as the caregivers, and my generation is the ones that are bearing a significant burden of this at the moment, are excluded from the diagnosis, we're getting kind of placed this burden of caregiving against our ability to intervene early on.
Yeah, so thank you. That was really important, both information and a question. So there is, I will say, discussion of the importance of identifying the caregiver in that situation and bringing them into the care part of the decision making. That conversation that was a little bit distinct than what you have brought up, which is that this is an important moment before the person has already been diagnosed. It's on that pathway. And there are a few kind of important things that we have learned about that earlier part. There are very important barriers to identifying the cognitive impairment. Some of it is cultural, some of it is knowledge-based, which is solvable, right? We can inform people better that cognitive impairment is not part of the way that, it's not part of the normal aging process. So there are kind of approaches to kind of reducing those barriers for the early detection by the individual and the family, which is different than what you're asking, which is how do we solve the HIPAA problem? And I don't know, I have a good answer to that. But there's this other side too, where 85% of the care and detection diagnosis occurs in the primary care setting. So primary care doctors, it's not specialists, are the ones detecting and diagnosing. And we see that there's a lot of variation in physicians' willingness to detect and diagnose. And again, I think that's an important intervention point. Some of it is related to feeling comfortable with what do I do now if I have if I detect this or I diagnose this with my patient. Do I have the ability to work through the next steps with my patient? I'm not trained, or am I trained in that? So that's something that I think is solvable. I mentioned some other tools that can be used that help with this process. So I guess the way I'll kind of wrap up my answer is that there are many places that have been identified as opportunities for addressing what you're talking about. But I think the one that you started with, which is how do we create an opportunity for a family member to early detect and share with the physician around HIPAA laws, is not something that, at least I know, has been directly addressed.
Hi, I have a very, very broad policy question. I lost my parents a long time ago, kind of learned about that. Oh, there's no long-term care payment under Medicare, what? And I was a Medicare lawyer. So, looking at the federal budget and kind of asking maybe are you asking for some public investment in this in some form? Currently, our budget is a whole bunch of Social Security and a whole bunch of Medicare, and a lot of other things are being squeezed out. So here in Texas, I think it was Lieutenant Governor Patrick, you may think of him, wanted more money for like a dementia task force or something. So again, for that older population. How do we think about it broadly as any investment that goes into dementia care and that type of thing? Does it take away from investment maybe in younger people? I know we want all of the above, but is there a trade-off, and how do you think about those trade-offs?
Yeah, that is a great question. I think there's always a trade-off with limited resources. So you try to grow the pool of resources. One thing that I didn't really touch on, which I think your question brings up, is kind of thinking, if we step back and we think about this from the macro perspective. So we have, let's say we wanted to fully fund long-term care for everybody. We know this is costly, and as you mentioned, you trade off spending in other places. But it's not as simple as that, because what you also do when you fund long-term care is you relieve 50% of those caregivers who are in the workforce to continue in the workforce. We haven't really monetized that. When they work, they're contributing tax revenues, growing our GDP, enlarging our pool. So that's, I think, one part of the answer to it. The other is really not an economic answer. It's more about What do we value? What do we want to spend our money on? Before Part D, people would have said, there's no way we can afford a prescription drug benefit. That's just impossible. But then there was a political will, and we did it, and people spend less for their drugs. Do we have the political will to put our money into providing for care for a very large growing population that is not just benefiting that population, but it's benefiting all the families generationally? So I guess that's my answer.
Hi. I have definite personal opinions about this because I have an early onset Alzheimer's diagnosis. And one of the things I think a lot of people need to remember is that this is not something that anybody chooses, because you can't pick your ancestors. It's also something that should not be perceived as shameful. And I know there's plenty of people with family members who are like, oh no, that can't happen. Well, Social Security starts at 65 because that's when most people died back when Social Security was implemented. And I think we got a whole lot of research and looking that before we're going to really make a big dent in this, because you get the genes that continue it before you're born. And so until and unless there's some kind of early intervention, that it's just going to keep happening, and we're going to have more and more and more people, because with the wonders of modern medicine, a lot of us are living longer. So hopefully everybody will consider doing a durable power of attorney to your children, that in case you do develop dementia. And I hope for everybody to learn something here and to think about policy changes that need to happen, because as a physician, I have decent coverage for my long-term care, but we're going to need assistance for a whole lot of people to keep any of their children working and making money.
Thank you very much. Thank you for coming and sharing your story with us. The voices of people who are living with this disease are very important for moving forward this research. And I've learned a lot from having the opportunity to speak with people who are living with the disease and the challenges they face. And so I hope you keep getting your voice out there. It really helps us move research in good directions and beneficial directions.
Yeah, thank you for the presentation. So my question is about some potential correlation to the other long-term disease. So I just read, I think like 86%, like a large percentage of dementia patients actually also has other like chronic disease, like diabetes or wound, chronic heart disease, etc. So just wonder, have you noticed like the policy change in dementia particularly has also had some ripple effect to the other chronic disease, or vice versa? What correlation have you noticed, and just give us some insights?
Thank you for your question. First, your point is very well taken, that persons with dementia are living with many comorbid conditions on average. You bring up a whole other topic I didn't have time to talk about, which is the risk associated with dementia driven by other diseases. So there are co-pathologies that exist with dementia and diabetes, with dementia and vascular disease. And there is a lot of really strong and also advancing research in that area that I didn't have a chance to talk about. But one of the studies that was recently released was the US Pointer study, which was a lifestyle intervention, and they addressed lifestyle. So that is, things that are good for your heart or good for your brain. So exercise, the food you take, the stimulation for your brain. And what the study found was the lifestyle intervention over 2 years improved cognition, but also improved other markers of biological aging and disease. So better glucose control, lower blood pressure. So there is both a lot of evidence of the relationships, both causal and driven by shared pathologies. And really, I think, important advances being made in that area also in terms of our understanding how we might address dementia through addressing vascular health that has spillovers to other diseases. Thank you. Thank you for your great questions. Thank you.
So we reached the end of our speakers. I hope you've enjoyed them as much as I have, and I learned an incredible amount. I wanted to thank all of you for coming today. We do this every other year. We'll be back in another 2 years, and it will be very interesting to see what things look like in the healthcare landscape after 3 years of the Trump administration. So please look out for that and see what happens. I'd just like to briefly thank all the people. There's all sorts of people behind the scenes who make this event possible. Our event staff is absolutely wonderful. So Laura and Maggie and the other people back there, and also my staff, Mara and Tashandra, have been wonderful in terms of getting everything else organized. And there's a whole audiovisual team back there who is carefully watching over things and what actually goes on. So you haven't heard from me today, but if the folks back there could put up a slide, so I won't hold you up with any of my work. You've seen us discuss. There's been a little bit of mention about price transparency from three of our different speakers. So my view, if you have time, there's a podcast. It's called The Arm and a Leg Show by Dan Weissman. It's one that I thoroughly enjoy. And the latest episode is he speaks with me and a couple of other people on a research project. So I could really use your help if you're willing to share your medical bills. This is anything from 2025 that you've gotten a bill for from a hospital or a physician. If you have Medicare fee-for-service, unfortunately, I can't get any help from your bills. But if you have Medicare Advantage, please do share those bills as well. And the podcast explains that whole situation. So thanks very much. I hope you have a wonderful weekend. I hope you don't get too wet, but we do need the rain, and hope to see you again in 2 years.